Today we are going to learn about the non-neoplastic endometrium from the stalwart, that is Dr. Anita Borges ma'am. She's the lab director and pathologist at the Center of Oncopathology in Mumbai. Here are our participants. I kindly request you all to please introduce yourselves.
Myself, Dr.
Sheetal.
Sheetal. I am second year resident from BJ Medical College, Ahmedabad.
Myself, Dr. Asam.
Myself.
I'm from Tejpur Medical College, Assam. First year PGs.
Myself. Valavalkar Medical College, I'm second year resident.
Everybody
Nargis?
finished? Myself,
No.
Dr. Nargis Ahmed. I am a second year postgraduate resident in Silchar Medical College.
Simi is muted.
I'm not me. I'm a Indian resident in Dayanand Medical College, Ludhiana.
I am Dr. Vanna, second year resident from SN Medical College, Agra.
Okay. Asma? Asma, are you there?
Yes, ma'am, I'm there.
Just introduce yourself, Asma.
Yeah, yes, I'm Asma Husniara. I am first year postgraduate trainee from Tejpur Medical College, Assam.
I don't think Shikha's there. Is Shikha there? I don't think so.
No, Shika is not there.
Yeah,
Dr.
so
Molina.
Shikha and Madhumita are not there. So now it's Mulian, introduce yourself.
Myself,
please.
Dr. Mugilan, second year PG from Sri Venkateshwara Medical College, Puducherry.
Okay, good.
The moderators for today's session are myself, Dr. Pooja Gajaria, and with me there is Dr. Parul. Our webinar hosts are respected Dr. Anita Burgess ma'am and respected Dr. Sumit Gujral sir. Few reminders before we begin. In case of connection interruptions, low or no sound, or if there is video freezing or lag, kindly leave the meeting and rejoin with the same link. If the problem persists, please check the network connection. I think, ma'am.
Sorry, that's all right. Carry on.
Yeah. Please answer the questions, if any, by typing in the chat box. And please do not send requests for annotations to the presenters. Few disclaimers. Our upcoming talks are on 17th September by Dr. Santosh Menon sir on ovarian neoplasms, and on 19th September we have clinicopathological case discussion by Dr. Arvind. So with this, let's start our today's talk and learn about the non-neoplastic endometrium. Ma'am, over to you.
Thank you.
Yeah.
Thanks very much.
Thank you.
All right. Good evening, everybody. It's today's talk is about the non-neoplastic endometrium. So you've already, in fact, had talks on the neoplastic endometrium. I think there is again, I don't know why we've got this, this. Can you hear me, or is there this echo?
Yes, we can hear you, Anita. Clear.
Very
Yes.
good. All right. So this is the non-neoplastic endometrium that we're going to be talking about. You've already heard about the neoplastic endometrium, somehow or the other, and trophoblastic disease. This should have been before you heard about the neoplastic endometrium, but nevertheless, this is a very common thing that we, the common gynecological specimen that we receive. I'm sure every one of you, whether you're a first year or you are a second year, or, if there are those who are practicing pathologists, you cannot get away without seeing an endometrium at some stage or the other. And that much of what you see will be benign. So these are just some common gynecological specimens. You have the endometrial curettage or a biopsy or a trans cervical resection. These are all different ways in which you will get an endometrial specimen, right? A very common specimen is a cervical biopsy, but we're not going to talk about it today. And then, of course, everybody sees hysterectomy. Hysterectomies for benign disease of the uterus. And most of the time, it is for what is called abnormal uterine bleeding. Once upon a time, it used to be called dysfunctional uterine bleeding. I think that there are many people who call it dysfunctional uterine bleeding. The international gynec consensus is that we should stop using this word dysfunctional uterine bleeding and call it abnormal uterine bleeding, whatever. So either of the words you will understand is what the majority of the hysterectomies are being done for. I wish it were not so, but that's what it is. Of course, you also see fibroids. Yeah, and nowadays we're getting these hysterectomies and fibroids, etc., that are not done through an open laparotomy. It's being done through a laparoscope. And when you see the material that comes through a laparoscope, it's often not intact. And you get both sometimes the uterus or the fibroids that are morcellated, that they're made into long strips. It's almost, like thick chips of tissue. And sometimes it's very hard even to find out where the cervix is in all of these chips of tissue. Okay, yes, you get hysterectomy with bilateral salpingo-oophorectomies and lymphadenectomies. That means the dissection of the pelvic lymph nodes for uterine cancer, which of course we are not going to talk about at all. And the other gynec specimens are ovarian tumors. You have radical hysterectomies for cancer of the cervix. And you heard last on Tuesday a really very nice exposition of trophoblastic disease. So these are the common gynecological specimens that you will come across. And today we're really only going to talk about the endometrium. Okay. Now, I want somebody over there to volunteer, but if nobody volunteers, then I will ask. Simi, you see a picture here of the endometrium, right? Are you there, Simi? Is Simi there?
Yes. Dr. Simi, please unmute yourself.
Yes,
Are you, very good, Simi. You see this? Do you recognize it? What is this
Yes,
a picture of?
this is a picture of endometrium.
Endometrium. All right. Do you think it's a curettage, Simi?
No, you can see all the layers of endometrium. So
Very
it is a
good.
deeper biopsy.
It is what, sorry, Simi?
Deeper biopsy.
A deeper biopsy. Why do you think it's a biopsy, Simi? Can it be a part of a hysterectomy?
Yes, ma'am.
Yes, it can be. Okay. So it is all the layers of the endometrium are there. So now, Simi, you've practiced how to do annotation, right?
Yes.
All right. So come on now. Will you with your annotation, yeah, show me what are these layers of the endometrium? You don't have to circle them. You can just draw a line from here to here. From then you just say what it is that it is. I'll just give you an example. You can just draw from here to here is whatever you think. I'm just drawn something outside of just to give you a way of.
This is the superficial part. This is stratum functionalis, and this is the deeper part. That is stratum basalis.
Very good. So you have got two parts of this endometrium. Is there any other part to this endometrium, Simi?
There is also an endometrial lining.
Excellent. So, Simi, can you point out to that endometrial lining? Yes, so this is the endometrial lining. All right. So most people miss out the fact that there is an endometrial lining. Okay. So why is it important, Simi? Just to reiterate once again. Okay. From here to here, yes, is what you called the functionalis, right, Simi? Yes.
This layer changes with the
Yes.
menstrual
Why did we
cycle,
call it
parts
the
of the menstrual
functionalis?
cycle. This layer it undergoes changes with the menstrual cycle, normal menstrual cycle.
All right, excellent. So that's the functionalis, and it's called functionalis because it actually has a function, right? What is that function, Simi?
The glands, they have a secretory function and they support the developing ovum when it gets attached to the endometrium.
All right. So that's the functionalis. And you also showed the basalis. Now, what does the basalis do? What's the purpose of that basalis?
It's a regenerating layer.
Regenerating meaning it gives rise to the functionalis, right? Why does it need to do that, Simi?
When we have the menstrual phase of normal menstrual cycle,
Yes.
there is shedding off of the superficial functionalis.
Okay.
And then again, after when the estrogen starts rising again in the next cycle, the proliferation of the endometrium begins in the basalis layer. And then
All right.
again,
So that's fine. I hope there is nobody who has any problems with that. Okay. Is there a difference, Simi? You've been you know your endometrium really well. So now tell me, is there a difference? Would you be able to identify if you didn't have this whole section where you can see the superficial endometrium, the functionalis, and the basalis? Yeah. Would you be able to identify the basalis if you got a curettage?
slightly difficult to identify along
Slightly
basalis.
difficult. Why is it slightly difficult? Why would you have difficulties in it?
Because of the morphology of the glands, they change with each phase of the menstrual cycle.
You just told me, Simi, that the basalis does not change with the menstrual cycle. You said that, right?
Yes, maybe.
So then where is the question? You should be able to identify the basalis. It's not going to change with the menstrual cycle.
That's
So
usually
how would you identify the basalis if you had to?
That's usually a single layer of cuboidal epithelium, the columnar epithelium.
Uh-huh. And you think that the normal endometrium has got multiple layers? Is that what you're saying, Simi?
Pseudostratification is there.
Pseudostratification of what?
Columnar
Cells?
epithelium.
Really? You mean that the endometrium is lined, endometrial glands are lined by multiple layers of epithelium. We'll see that in a minute, Simi, but I think that you are making a mistake for something else. Let's ask one of the others. All right, Simi's answered a lot of questions. Sheetal, do you think that that you would be able to identify the basalis in a curettage? Yes? Do you think so? Sheetal,
No, ma'am, it's difficult to
it
identify.
is difficult. Why is it difficult, Sheetal? I asked the same question. Simi said it was difficult, and I asked her the same question. Why? Do you agree with her? Because it's a simple lined endometrium. The rest of them are at the endometrium can have multiple layers. In other words, it is stratified. Yes?
No, ma'am.
No. So then why is it difficult in a curettage? Why should it be difficult in a curettage? Have you ever tried to identify, yes? Have you ever tried to identify the basalis? Answer yes or no. Come on, Sheetal. Have you?
No, ma'am.
No, ma'am. All right. Very good. Rupali,
Yes.
have you
Yes,
ever
ma'am.
tried to identify the basalis in your curettage? Because curettage is the common thing that you see, right?
Yes, ma'am.
Very good. Have you ever tried to do that?
Yes, ma'am.
You have tried, and have you able to see the basalis?
Yes, ma'am. It is an inactive glands are seen in basalis.
Inactive glands. Really? You've been able to see inactive glands? How would you
There
know
is
that
no
a gland is inactive?
there is no mitosis seen.
There are no mitoses. All right. So now if you have a resting endometrium, okay, just before, just the first, or the after menstruation is over and there is the early proliferative phase of the endometrium. Yeah, the glands are inactive, are they not? So how do you have actually seen inactive glands? Really? Sheetal, have you tried and you have said to yourself, this is basalis? Yes? That's Rupali, sorry. Okay, let's ask Vandana. Vandana,
Yes, ma'am.
tell me, have you
Ma'am.
ever identified basalis?
No,
Some
ma'am.
people in the chat box who are saying what I expect you guys to say. Yes, Vandana?
No, ma'am, because endometrial lining is not present in the curettage.
Yes. So Vandana, that is absolutely right. All right. See where the basalis is. Okay, the basalis is way down in the endometrium. Okay.
Ma'am, sorry to interrupt.
Yes, Asma.
I will be available. I'll come after a few minutes. My baby is crying so much.
No, that's all right, Asma. Please carry on. Carry on.
I'm so sorry. I'm so sorry.
No, not at all. You're. Thank you for coming on at all. Okay.
I'll come again after some time.
That's okay. Not to worry. All
Thank you
right.
so much.
See now, see where the basalis is. Basalis is here.
Yes.
Okay.
Yes,
So
ma'am.
when somebody is doing a curettage, I think that it would be a real curettage that is so very vigorous that they have got the basalis. Should they get the basalis at all? Huh, Vandana?
No,
What?
ma'am, in curettage, not all.
What did you say, Vandana? They should not
Yes,
try
ma'am.
to
Should
get
not.
the basalis. It is very deep. So it
Yes.
means that somebody has done an extremely deep curettage. And if you do a very deep curettage, Vandana, what is likely to happen? What are the consequences of a very deep curettage? Somebody in the chat box is saying
Instrumentation injury will be
saying
there.
infertility.
They will perforate the uterus.
Perforate the uterus. Vandana.
No, ma'am.
Synechial
Injury
formation.
to the slightly injury.
Somebody
In
said
post instrumentations,
Synechial formation.
synechial formation, adhesions will be there post instrumentation.
Yeah, adhesions between what and what, Vandana? What adhesions? Adhesions between what? Everybody is saying Synechy, people are saying
Yes.
adhesions between what and what? An adhesion
Wall of
means
the
what,
uterus.
Vandana? Yes, yes,
Ma'am,
Nargis.
between stratum functionalis and basalis layer.
Adhesions between the functionalis and the basalis layer.
Fibrosis.
Meaning what?
Between the wall of uterus, ma'am.
Between the wall of the uterus. So what do you mean by that, Sheetal? Huh? What do you mean? See, you people can see, that here you have, what do you have here? You have the lining epithelium, and that lining epithelium, which is seen over here, which I have shown. Yes?
Yes,
This
ma'am.
lining epithelium is lubricated. If you take away the functionalis altogether and you've got a basalis, what will you be left with? You will be left with what?
Myometrium.
Yes. And you take away the basalis, you are left with the myometrium. And the myometrium has got no epithelium on top. So what is likely to happen over there? You will start getting granulation tissue. And that granulation tissue is going to form adhesions with the other side of the endometrium. Yes, that's what happens if you peel off the entire endometrium, including the basalis. So if somebody says, yes, I am able to identify the basalis, and you have seen it very often, that means whoever is giving you your curettage, those gynecologists are literally scraping, as we say, the bottom of the barrel. It cannot be so. And you do know that you have reached the basalis, sometimes just by chance, or the gynecologist, this is a postmenopausal woman, and that gynecologist is not bothered about whether there will be adhesions or no adhesions or whatever, because if there are adhesions, if there are synecdoche, the patient has problems conceiving, etc., and the gynecologist doesn't care, you may get some basalis. And people have been writing there in the chat box, and I think Vandana said it, that you will see glands, and I will show you in a minute. Let me just take away this, all these annotations. Yes, you will see. That's the functionalis, as I've shown you over there. That's the basalis. This is the endometrial lining. I am not going to get this annotation request, okay? Please, I will only take the annotation requests from the students who are here, because otherwise we'll have no end to the annotation. That's the endometrial lining, okay? And here is the basalis. Now, I just want you to look at the basalis, okay? Most of the time, you guys see the functionalis. So you see secretory phase endometrium, you see proliferative phase endometrium, and just look at the glands of the basalis. What do you notice about them, Vandana? What do you notice about the basalis glands, which you don't see in this particular picture, which is showing you the functionalis, and that functionalis is in the secretory phase? What do you see?
Few inactive tubular glands.
Inactive. You don't know that they are inactive, but what do you see? Are they tubular? If they're tubular, what kind of tubules are they? Yes, Sriram is right. He says that they are, Sriram is in the chat box, that this is star-shaped. You see that they are branched. Okay?
Yes,
they are
branching functionalis.
The basalis glands are often seen as branched glands, which you don't see. You don't see it in the secretory phase. You don't see it in the proliferative phase, but you begin to see branched glands in some other benign endometria, okay, other benign processes in the endometrium. So you can understand that if we have these kind of, and you keep on saying inactive, yes, single layered endometrium with these branching glands, and you do not see an endometrial lining next to it, then this is basalis. Okay, please, this is how you recognize basalis in the rare occasions when somebody has got the basalis in the curettage. All right, very good. So now let's get to endometrial physiology. That was just the normal endometrium looks like. Now we can have physiologic endometrium in many different stages of life. Prepubertal, cycling, that is during the reproductive age group, pregnancy associated, as well as postmenopausal. Okay. Now let me ask, Asma is gone. Nargis, yeah, tell me.
Yes, ma'am.
Have you ever seen prepubertal endometrium? It's a simple yes or no question, Nargis. Have you seen prepubertal endometrium?
No, ma'am.
No, ma'am. Why is it that you haven't seen prepubertal endometrium? Why? Is it impossible to see prepubertal endometrium? Or why is it that you have not seen? Because your institution is not dealing with pediatric patients. Do you have pediatric patients, Nargis, in your institution? Yes? Nargis, say yes or no. Do you have pediatric
Yes, ma'am.
patients?
We do have
You
pediatric
do.
patients.
So do you feel that you should be seeing prepubertal endometrium? Huh? All right. So Nargis is thinking about it. Very good. Mulian, have you ever
Yes,
seen
ma'am.
prepubertal endometrium?
No, ma'am.
You haven't. Why?
There is no need for curettage or a examination in the
There
prepubertal
is no
thing
need.
unless there is an
There is no need. Why is there no need? Now, why, Mulian, is there no need?
yes, ma'am. There won't be the functionalis layer, ma'am. Only the basal layer will be there, and
Only the basal layer.
it won't be mature enough. Yeah.
So,
And the hormonal induction is not there, the prepubertal endometrium.
okay, all right. Do you, right, do you think that that people will, even if the patient has problems, do you think anybody is going to do a curettage of the endometrium, Julian? No, no. Even if if say somebody, if you have a pubertal child who is pre-pubertal child, say an 8-year-old girl, 7-year-old girl, yeah, and she's spotting, and the parents bring her to the hospital and say that my child has got spotting per vagina. All right. Yeah. What would the doctors do, Julian? She's got bleeding. So what would they do? And say she's 7 years old. What would you advise them to do, Mulian? DNC?
No, ma'am. Probably first thing we have to examine and do an ultrasound.
Do an ultrasound. Very good, Mulian. For what? For what?
To know the cause of bleeding, ma'am.
The cause of the bleeding. So what cause of the bleeding will you find possibly in a 7-year-old girl who's bleeding from her endometrium? We expect or we suspect that it is from the endometrium. What will we find on ultrasound, Mulian? Huh? All right, Mulian, let's let Mulian think about it. Simi. Yeah, Simi.
Then it could be an ovarian cause.
Could be
in
an
a pre-
ovarian cause. Okay. What ovarian cause, Simi?
Then there could be excessive secretion of estrogen, under which the endometrium is bleeding.
Excessive secretion of estrogen from what in the ovary?
Possibly a tumor.
Possibly a tumor. All right, an ovarian tumor. Very good. Then anything else?
Precocious puberty can be a cause.
Precocious puberty. Yeah, this child is not 2 years old or 3 years old. No? The child is 7 or 8. And nowadays, you know what? At what age children are becoming pubertal?
Usually 9 or 10.
It's not 9 or 10, it is 7, 8, 9. So you're doing an ultrasound to see if there is a developing follicle. No? So that's the first thing that we would do. Is she attaining menarche? So that's something that one would have to do. And yes, you will have to do an endocrine workup. Certainly, you're not going to do a DNC, or you're not going to whip out a uterus or anything of the sort. Yeah, you will be doing an ultrasound, and that's why Mulian was right. You will do a pelvic ultrasound. You will also look at her adrenals, and you will look at the pituitary ovarian axis, because we want to know what is going on in all of these organs, because whether it's the pituitary or it is the adrenal or it is the ovary, all of them have a big role to play in the physiology of the endometrium. All right, but by and large, everybody is right that you are hardly ever going to see a pre-pubertal endometrium unless it's for some reason or the other, for some malignancy or the other, the patient has had the uterus out along with the ovaries and other such things. You will not see a pre-pubertal endometrium unless it happens to be on the autopsy table. Okay, so you're taking out the organs and then you can look at the pre-pubertal. So you're right. Okay, then of course, this is the cycling endometrium, and you can have two kinds of cycling endometrium. One of them is ovulatory and the other one is anovulatory. All right, so what is the meaning of cycling, Sheetal? Sheetal, what is a cycling endometrium?
Ma'am, in case of cycling endometrium, endometrium proliferation, secretion, and secretory phase, and menstruation phase.
So that is the meaning of cycling. Then what is ovulatory and anovulatory? So what do we mean by cycling? What is this cycle? We have lots of different cycles. Menstruation. So what is a cycle, Sheetal? You have diurnal cycles, you have different cycles, no? So what is a cycle? What does a cycle mean to you? When do we say that in this case, of course, it's the endometrium that is cycling, but the cycle means something, no? We talk about a cycle has got a wheel, right? So you know that so something happens again and again and it goes round. You know that we have a cycle of day and night, or not? Every day is a cycle, right, of day and night. And you know why a bicycle is called a bicycle, Sheetal? Why? Why is a bicycle called a bicycle? Bicycle. Why is it so?
Bicycle.
Why? Because it's got two wheels, right? Bi meaning two, and the cycle, and it goes round and round, reaches the same place again and again. So that is the meaning of the word cycle. So it doesn't have anything to do with going through a proliferative phase and then a secretory phase and then a menstrual phase, because you can go straight from a proliferative phase to menstruation and back again through proliferation to menstruation. When does that happen, Sheetal? When does that happen? Can you have just a proliferative phase and then menstruation back again to a proliferative phase?
In
When
case
does
of
that happen, Sheetal?
anovulatory cycle.
And there I put it up, right? So a cycling endometrium can be ovulatory or it can be anovulatory. And lots of people are answering that in the chat box. Then, of course, you can get a physiological endometrium, which is pregnancy associated, because pregnancy is not a disease. It's physiological. And then, of course, postmenopausal endometrium. Okay. So all of these are entirely physiological. Now, I'm sure, Sheetal, you're asking, is an anovulatory endometrium, is it not pathological? So come on now, Sheetal. Is anovulatory endometrium pathological? It's cycling, all right, but is it pathological?
Ma'am, mostly in physiological case, in case of the pre-puberty, which is the normal.
Not pre-pubertal, it is post-pubertal, my dear.
Post.
Yes. Yes, come on. Yes, you're right. What? It is?
So only.
So anovulation
in case of the PCO,
is perfectly physiological at what? When?
Pre-menarche.
Again, you're saying pre-menarche. What is menarche, Sheetal? What is menarche? Sheetal, do you know what is menarche? All right, somebody has to tell her what is menarche. Rupali, what is menarche?
Starting of the menstruation.
Starting of menstruation. So can you be menstruating before menarche? Can you? She's saying pre-menarche. That's why. Can you menstruate before menarche? Yeah? You can, Rupali? Sheetal and Rupali, both of you know that menarche is the start of menstruation, right?
Yes, ma'am.
So, okay. So anyway, you are in adolescence, just menarche and post pubertal, you will get anovulatory cycles that are perfectly normal. You will get anovulatory cycles just before menopause or perimenopausal. And every woman during the reproductive age group at some stage or the other will have anovulatory cycles, and they are absolutely physiological. There is nothing that is pathological about anovulatory cycles unless there is a pathology that is giving rise to anovulatory cycling. All right. So it is there by itself. Anovulatory cycles are not pathological unless there is some pathology that is giving rise to anovulatory cycles. Okay, very good. Now let's go to the next thing. This is the menstrual cycle. Okay, and I just want you to pay attention to the menstrual cycle, because the menstrual cycle is really the basis of understanding what is going on in the target organ, which in the menstrual cycle, the target organs are the ovary and the endometrium. And if we have to understand what is going on in the endometrium, then we must know what is going on in the pituitary and what is going on in the ovary. Now, you know, this is the top line is the ovary. The middle line over here is what's going on, you know, at the different phases of the endometrial cycle. And we have to match what is going on. What's going on here in the bottom thing is what's going on in the pituitary. All right. So once you know this and you understand it, it becomes very easy to understand what's going on in the endometrium. All right. So here it all starts in the pituitary. In the pituitary, you have what is called FSH, which is follicle stimulating hormone. And you start, this is the start of menstruation. And here we have what is called the follicular phase of the ovary, and you have the luteal phase that happens in the ovary. So you at menstruation, you see that the follicle stimulating hormone is coming down. Okay, you'll see that FSH starts to rise when you are almost in the between menstruation, after menstruation, you will have high levels of follicle stimulating hormone, because the follicle stimulating hormone actually causes the development of the follicle. Okay, at the time of ovulation, both the follicle stimulating hormone as well as luteinizing hormone rise very sharply. And you can just see what's happening to estrogen at that period of time. Estrogen is slowly rising. And where is this estrogen coming from? Estrogen is coming from the developing follicle. There is the highest peak of estrogen just before ovulation, and that's also the peak of the follicle stimulating hormone. And then when the peak of follicle stimulating hormone is reached, you have a luteinizing hormone that is released from the pituitary, and luteinizing hormone is responsible for ovulation. Okay, so you cannot have ovulation without the luteinizing hormone. And then thereafter, progesterone starts to rise. The amount of estrogen comes down, but estrogen never really disappears from the system, but you have high levels of progesterone. But just before menstruation, both estrogen and progesterone fall. Progesterone falls very sharply. Estrogen, of course, falls, and then goes back to its level, which is at the time of menstruation. Slowly, under the influence of follicle stimulating hormone, the estrogen will rise in the next cycle because it is being secreted by the developing follicle in the ovary. That's why it's called the follicular phase. And it's called the luteal phase. Why is it called the luteal phase, Vandana? What is this luteal? Where is Vandana? Are you there, Vandana? Vandana, are you there? Or have you disappeared? Rupali, you there? You can hear me?
Yes.
Very good. So why is it called the luteal phase?
There is a formation of the corpus luteum.
There is a formation of the corpus luteum. Yeah. So what is this luteum? Do you understand why? You see the color that is here? What color is this? Sorry? You see this color? There's brown in the middle, and that brown is what?
L.
What is brown? What is brown? This is the ovary, right? So you have ovulation. And so why is this central part of this painted brown? Why? All right, Rupali doesn't know why it is. Mullian, why is the center of this thing painted brown? Where is Mullian?
Yes, sir.
Why?
So there will be some amount of hemorrhage inside that.
Very good. So brown represents hemorrhage. So it starts off by being a corpus hemorrhagicum, right? And then it becomes a corpus luteum. So why outside the brown there is a color? So what is this color, Mullian? It's being painted here, no? What color?
Yellow color, ma'am. It's
yellow. So why is it being painted yellow, Mullian?
It's made of that graphene follicle cells and luteal cells.
Graphene follicles, but why is it painted? Why have I colored it yellow? I could have colored it green or blue or left it uncolored. Why is it yellow? Come on, Mullian.
Because it acts as a secretory function.
Not because it acts as a secretory function. Okay, it is lipid rich. It is full of lipid. Yeah, and if it is lipid, it's going to be yellow, and the word for yellow, it comes from the Greek word luteos. That's why it is luteal. Okay, so the luteal phase is called the luteal phase because that corpus luteum, corpus meaning what, Mulian? What is the meaning of the word corpus? What's the meaning of the word corpus? Anybody, any of you? Simi, what is corpus? Somebody in the chat box says uterus. No, wrong. Simi,
It's a collection, ma'am.
Huh? Lots of people are saying it in the chat box. So what's wrong with my 5?
So used for dead body.
For dead body? No. That's a corpse. Corpus means body. All right. So we have so many corpora. Okay, and that's the word corpus means body. So when that body becomes dead, you call it a corpse. That's a different story, but it is a dead body. Yes, that's a corpse. The same word. It comes from the same word. Please, you guys have to be a little bit more curious about the language that we use. So that's why there's the corpus luteum, luteus meaning yellow. Okay, and it is yellow because it is full of lipid, and it is full of lipid because you have again the same word, luteinization. Yeah, luteinization means collecting lipid which makes it look yellow. So you have the luteinized theca, which is full of cholesterol. Yes, you know that. Estrogen, progesterone, what is the basic structure from which these hormones are manufactured? The basic structure is cholesterol, and cholesterol is there in large amounts in any lipidic situation. Okay, and that's why it is yellow. You've seen the adrenal cortex ever? That adrenal cortex is yellow. It is because it's full of cholesterol, because all the adrenal hormones are being manufactured from a cholesterol base. Okay, so now that is the normal cycle. But there's something that you have to understand about this cycle. Okay, it is to do with the function of estrogen and progesterone. Estrogen promotes proliferation. Without estrogen, the endometrium cannot proliferate. And without progesterone acting on an estrogenized endometrium, there can be no differentiation. And what is that differentiation that we are talking about? This differentiation is secretions that collect in the endometrial cells and then are extruded into the lumen of the endometrial glands. And this is very important because this endometrium has to form a bed for the fertilized ovum as it comes and sits in that bed. Okay, so if a fertilized ovum comes and sits in a bed that is only estrogenized, there will be no implantation. So it requires progesterone to make this endometrium fully functional. And if the function of that endometrium at the latter half of the cycle is not fulfilled, then that disappointed endometrium begins to weep. That is how, physiology was taught to people, that the endometrium is sitting there in expectation of, the ovum coming into that endometrium and being implanted. And if there is no implantation, then the endometrium starts to weep and you get the menstrual cycle. So remember this, please. Estrogen promotes proliferation. Progesterone promotes differentiation, but please mark my words, it promotes differentiation only if it has been primed by estrogen. So you have estrogen, which has promoted proliferation, and to that system, as you see over here, through the luteinizing hormone, which is now producing progesterone from the ovary, ovulation has taken place, progesterone is being produced, which acts on an estrogenized endometrium to produce differentiation in that endometrium, is what we call the secretory phase. If the progesterone is kept there long enough, and that can happen not under the influence just of the corpus luteum, it's under the influence of beta HCG, which the ovum which has implanted into this endometrium, the trophoblasts and start to produce beta HCG. That beta HCG produces even a greater differentiation of that endometrium, and then you get pregnancy associated changes like decidua. Okay, so this is the menstrual cycle. Now I want to ask a question, and people can answer in the chat box. Okay, any one of you can take this question. Okay, Vandana, is Vandana there, or has she disappeared? Are you there, Vandana?
Vandana has power issues in Agra.
Okay, so she's gone. All right, Nargis, are you there? Yes. Very good. Now, can you answer this question, Nargis? Here we've got all these pictures. All right. So what is the egg or ovum in a prepubertal ovary?
Oogonia.
Oogonia. Acha. Rupali, what do you think?
The oocyte.
Oocyte. Yes, you're absolutely right. It is the oocyte. Okay, the oogonium is seen only in fetal life. In fetal life, okay, you do not get, it becomes an oocyte even towards the end of fetal life. So when a baby is born, a female child is born, they are all oocytes. Okay, there are absolutely no oogonia. Not that, just like in the testes, you have spermatogonia. You don't have oogonia in an ovum in an ovary at any point of time. All right. So if that is about oocytes, now Simi, would you like to take this? Why does menopause occur? There are four options. The age reaches over 45, FSH levels drop, oocyte numbers are finite, and the ovarian capsule gets too thick for ovulation to occur.
There are fixed numbers of oocytes in the reproductive age group.
It's not in the reproductive age group. They're fixed numbers of. We are born with, the females are born with a fixed number of oocytes. They don't develop during. Suddenly you don't get more oocytes in the reproductive age group. And when the number of oocytes is exhausted, and you know that more than one oocyte is developing in that developing follicle, and that's the end of it. So that's when you get menopause. So it's nothing to do. And in fact, what happens to FSH levels, Simi, in menopause? Are they down or are they up?
When immediately after menopause, they are normal or slightly raised.
Or slightly raised, right? Anybody else? You look in the chat box and they'll tell you that FSH levels are very high in menopause. Why? Simi, can you tell me why?
Because of the absence of negative feedback from the
Exactly.
hormones.
There's no estrogen to stop the FSH from actually coming. So if you have very high levels of estrogen, FSH will be shut off. Okay, so there is absolutely no negative feedback, and therefore this is what happens. Okay, good. So just quickly to tell you the development of the ovum. See, here you have oogonia are there only in the fetal ovary. Okay, and in an early fetal ovary. Then you get oocytes, and the oocytes is in the neonatal ovary. So all women are born with a fixed number of oocytes, which only decrease with age. Okay, and then they develop in the developing ovary, and with each cycle you are getting the development of the ovum. And what is going on here? You have primordial follicles, and these follicles are nothing but the ovum that is surrounded by granulosa cells. Okay, and then you have the theca cells developing, and then each follicle, as it develops, it gets a fluid-filled cyst. And it's that fluid-filled cyst that reaches the capsule of the ovary, and ovulation takes place. And what do you think is in that fluid-filled cyst? Sheetal, what is in that fluid-filled cyst? Sheetal, are you there?
Yes, ma'am.
Sheetal has also got problems, maybe. All right, Rupali, what's in the fluid-filled cyst? Are you there, Rupali?
Yes, ma'am.
No, so then tell me, what is in that cyst? You can see the cyst. It's known as the antrum of the follicle. What is inside this cyst? So when the ovum is released, there's a lot of fluid that is released with it. What's in that fluid? Rupali? No? Nargis? No? Mulian? No? And I don't see anybody in the chat box getting very active either. Somebody saying progesterone. No. Somebody saying glycogen. No, for God's sake, it is estrogen. That is where the estrogen is coming from. Okay, it's the granulosa and the theca that produce the estrogen. Yeah, and it is all collecting in that follicle, which is filled with estrogen fluid. And let me tell you that one of the dreaded complications of hyperstimulating the ovary to collect a lot of eggs or ova for IVF is the dreaded complication of what is called a hyperstimulation syndrome, because all that estrogen with so many follicles be ovulating, they all get that estrogen goes into the pouch of Douglas and is absorbed rapidly. It's like the woman getting a huge injection of estrogen, and the woman goes into a vasomotor shock. So this is one of the really dreaded complications of multiple ovulation, which you bring all these ova up to nowadays. Of course, they have ways of taking the ova before it actually ruptures onto the into the pouch of Douglas. So remember that this is full of estrogen, and you can see a picture over here of all the developing follicles, and in this fluid is called the antrum. So you have the granulosa cells, and you have the spindle theca cells, and it's the granulosa cells that are producing estrogen into this. Sorry, this is the ovum here, and into this fluid-filled cyst, you get. I'm not going to tell you all the different parts of that ovum. It's for you to go and see. Okay, and here is a chart that shows how many ova you were born with and how they rapidly decline. So almost from the age of 25, you are, it's falling from the time you are born very steeply, and then the slope is less steep until at menopause, you are left with no ova at all. And if you don't have any ova, then obviously you don't have any granulosa cells. And if you don't have any granulosa cells, you cannot be producing estrogen. And if you don't produce estrogen, you cannot have a menstrual cycle. And you see that over here, 95% of women by the age of 30 years, 25, 30 years, only 12% of their maximum pre-birth, over non-growing follicle population is present. By the age of 40, only 3% remain. So this is the story of what is menopause. Okay, so once again, please be aware of the menstrual cycle, and I am repeating it like a mantra. Estrogen promotes proliferation, progesterone promotes differentiation, and I'm telling you why I'm going to tell this mantra you have to learn, because it has a very important connotation when you are looking at an endometrium. All right, so now let's come to the actual endometrium over here. All right, so who hasn't answered any questions now? Let's start with Sheetal. Are you there or you're not there? Is Sheetal there? I think
Yes, ma'am.
Sheetal and
Yes, ma'am.
you're there. Okay, very good, Sheetal. Come on, tell me. This is the proliferative phase. Okay, how do you recognize the proliferative phase, Sheetal? Why are we saying that this is the proliferative phase?
Ma'am,
Yeah. Okay, Sheetal. Nargis, I can see your picture here. You want to answer? Come on. Why do we call it the proliferative phase? Jaldi.
Ma'am, mitosis is present.
Yes, so mitoses are present. And it is because the endometrium is proliferating. And when something is proliferating, the only way that we know that it is proliferating is we can see mitosis under the microscope. Yes? Very good. You can see the mitoses there under the microscope. Okay? And it depends on which part of the proliferative phase it is. The earlier on in the proliferative phase, you may not see so many mitoses. As the FSH level, rises and there's more estrogen in the system, you'll get more and more mitoses until towards the end of the proliferative phase, you will not see mitoses. So please remember this. This is the hallmark of the proliferative phase. And let nobody tell you, oh, because it has, the things are round and gland in gland. I hear all sorts of things. Yeah, and look at the stroma. The stroma also, if you bother to look for it, is also mitotically active. So it's not just the glands that are mitotically active, it is also the stroma that is mitotically active. And let me tell you, Simi, that you said that there are multiple levels, there are multiple layers. There are no multiple layers. It seems as if there are multiple layers because the nuclei are at different parts of the cell. Okay, so there is a single layer of columnar cells with pseudo stratification of the nuclei. All right, now I'll show you this. Look at this. This is Ki67 or MIB1, and it shows you just how many of these stromal cells as well as glands, the cells of the glands are in mitosis. Okay, so it is a very active phase. So the proliferative phase is recognized by one thing and one thing alone. And what is that, Nargis? Say it loudly.
Mitosis.
Mitosis. Okay. So if you see mitosis, it cannot be the secretory phase. Please understand that. And why can it not be the secretory phase? Because you can never get differentiation if a cell is still proliferating. So for differentiation to occur, and this is in any system that you can think of, mitosis or proliferation has to be shut off. Okay, so you cannot, you cannot be doing two things at once, proliferating and differentiating. It's next to impossible. So if differentiation has to take place, then proliferation has to be shut off. So if you're seeing mitosis, then it's very unlikely that there is any differentiation taking place. So you see mitosis, be very careful about calling something a secretory phase, because the first thing that happens in the early secretory phase, when progesterone has come into this system because of the luteinizing, because of ovulation, and progesterone is now in circulation, the first thing that happens is that mitoses are shut off. Okay, and then you get the secretory phase, and here you are. This is the secretory phase. You can see early secretory phase here with subnuclear vacuolation, where all the nuclei seem as if they are towards the luminal surface. Yes, and here you're getting even more convolutions of these glands. You see how convoluted these glands are getting. All right, and you finally have a hallmark of a well-developed secretory phase is this structure. What is this structure, Mulian, that you're seeing in the bottom left-hand
Blood vessels
picture?
with predestination.
1 minute. What did you say, Mulian?
Blood
Blood
vessels with
vessels. Yeah, I think I can say that they are blood vessels because I can see red blood cells.
with the
What kind of
predestination.
blood vessels are there? Are they, Mulian?
Spiral
What kind of
arterioles
blood
with the
vessels? You know that there are many different calibers of blood vessels, right, Mulian? Starting with the
Yes.
aorta. I don't think this is the aorta. Do you think it's aorta, Mulian? No, no. Is it? Can it be?
spiral
No.
arterioles, ma'am.
Ah, there you are. So what caliber of blood vessel is it, Mulian? You know what is the meaning
Arterioles.
of caliber? Ah, there you are. So it is, these are arterioles. How do you know that they are arterioles, Mulian? How do you know that? You should be able to recognize them, no, as arterioles. So how do you know that they are arterioles? What is the hallmark of an arteriole, Mulian? What is the hallmark of an arteriole? How would you recognize an arteriole anywhere? Never mind about the endometrium. Yeah? Simi, how would you identify an arteriole?
From the layers of the blood vessels.
Oh, thank you very much, Simi. I know it's layers. So what layer?
Tunica intima, media, and externa.
Oh, really, Simi? Simi? Every blood vessel has that. So how do I know it's an arteriole? The aorta has it. So that then it becomes an arteriole. No, it cannot be that. No. All right, Sheetal.
Because of
Sheetal.
the elasticity, ma'am, the lumen will be patent.
Elasticity. Lumen will be patent. So lumen is not patent in an aorta. It is not patent in a major artery, in a smaller artery. It's not patent in a venule. Kya hai, Mulian? Huh?
In the
Rupali?
venules, it will be like compressed.
It's compressed. Yes.
Thick endothelial line.
Thick endothelium. You know, Mullian has identified this as an arteriole, no? So look at it and tell me, no? So thick endothelium.
Thick, no ma'am, thick, thick walls.
Vandana.
Ma'am,
Vandana is there?
arterioles. Yes, ma'am.
So how do you identify an arteriole? How do you identify it, Vandana? Nargis, how do you identify an arteriole? Whether it's here or in the... Yes?
Subendothelial layer.
Subendothelial layer? What is a subendothelial layer? Tell me. Lots of people have been saying things in the chat box. Huh? What?
Absence of tunica media.
Oh, no. It is a small blood vessel which has a thick muscular layer. First of all, it has to be small, and look at this muscular layer. It's all around it. You can see at the very plump muscles that are around this. That is how you identify an arteriole. Okay? All of you have done pharmacology. All of you know a lot of things, even physiology. Do you know that the arteriole is that part of your vascular system, which is just before the capillary bed? The capillaries have got no muscle layer. The small arteries have got even less of a muscular layer than the arteriole. Why? So why does the arteriole have such a thick muscular wall? Because it is that part of the vascular system that controls how much blood goes into the capillary bed. And why is that important, Nargis? Why is that important? Because it's in the capillary bed that many things happen. Oxygenation, deoxygenation. To have cold, and if your fingers become blue in the cold, why? Because your arterioles prevent blood from going into that vascular system. Otherwise, you'll start to lose heat, and you want to conserve heat. This is physiology. Now here you have not only do you have an arteriole, but it is a spiral arteriole. Okay? And there has to be a reason why in the endometrium you see that these, in the secretory phase, you have got this spiral glands and you have a spiral arteriole. Why do you have that? Because first of all, you cannot have the endometrium growing longer and longer. Right? So there is a fixed phase to this endometrium, fixed space, and the glands have to accommodate themselves. That's why they are curved and they are convoluted. And the arterioles are also convoluted because when during menstruation, you require the arterioles to clamp down to prevent excessive blood loss. And now you will realize why all women undergo menstruation, and within 3 or 4 days, the blood loss is down to minimum. Okay, that's because of the function of the spiral arterioles. Now imagine if you never had spiral arterioles, imagine how much blood you would lose. Now think of a situation, any one of you, when you don't have spiral arterioles and the woman bleeds and bleeds and bleeds for a long period of time. She has menorrhagia. Can you tell me, Nargis, a situation in which you will get menorrhagia because there are no spiral arterioles? Come on, Nargis. When does a spiral arteriole develop, Nargis? In which phase of the endometrium?
I'm in the secretory phase.
Secretory phase. Very good. So what happens in the proliferative phase? Is there a spiral arteriole? People are answering in the chat box. I can see it. Okay. So it has to happen in a phase where there will be no spiral arterioles. And there are no spiral arterioles if you have unopposed estrogen activity. So instead of 14 days of estrogen followed by 14 days of progesterone, in which you have 14 days of proliferative phase and 14 days of a secretory phase, during which a spiral arteriole develops and it prevents excessive bleeding. Suppose you have 28 days of estrogen, which means 28 days of a proliferative phase, and there is no spiral arteriole. Then what will happen, Nargis?
An ovulatory cycle.
You have an anovulatory cycle, and when you bleed from an anovulatory cycle, the bleeding is heavy.
And there will be withdrawal bleeding.
There will be what, sorry, Nargis?
Withdrawal bleeding.
Oh, there is always withdrawal bleeding. You have withdrawal bleeding in a secretory phase, you have withdrawal bleeding in a proliferative phase, but you bleed much more in an anovulatory cycle because there has been no progesterone. Anovulation means no progesterone. And if you have no progesterone, you have no spiral arteriole. And if you have no spiral arteriole, then you do not have a mechanism to stop the bleeding or keep the bleeding to a minimum. That is the function of this spiral arteriole, which develops under the influence of progesterone. So the spiral arteriole is another very important feature of a secretory phase, or whether you call it a secretory phase or a progesterone having acted on the endometrium. Okay, so first thing that you get in the secretory phase is that it shuts off proliferation. Progesterone shuts off proliferation, so there is no mitotic figures. The next thing that you should look for is the spiral arteriole. Okay, a lot of people look at the stroma. Oh, the stroma is very loose. Yeah, anything or everything can happen. But what you should really look for is the absence of mitosis and these very characteristic spiral arteriole. Okay, and just to show you what the Ki67 or the MIP1 index is, you can see. All right, it is spotty in the stroma. It is not as active as you saw in the estrogen or the proliferative phase. Good, excellent. Now everybody talks about decidua. All right. Now I want you to tell me, is this decidua? There are two pictures over here. Left hand, right hand, and there's this small little thing is a blow up that you see over here of what's going on. So somebody will like to take this question, Sheetal or Rupali? Rupali hasn't answered for a long time. Come on, Rupali. Left hand side decidua or pseudo decidua, which one? Come on, Rupali.
This is left hand side is a decidua, and
right hand side is pseudo decidua.
Pseudo decidua.
Why do you think so? What is the difference? What is decidua, by the way? Rupali? What is decidua?
It is
What is decidua? Rupali, have you ever seen decidua in your life?
yes, ma'am.
You have seen. So you should know what is decidua, right?
Yes, ma'am.
Oh, okay. Why do you think I'm going to ask Vandana? Vandana, what is decidua?
Ma'am, transformation of the proliferative stromal cells to large ovoid to round vesicle with eosinophilic cytoplasm, abundant eosinophilic cytoplasm.
It's transformation of what, Vandana?
Proliferative stromal cells to large ovoid to round.
Proliferative phase stromal cells. You're absolutely right. Now, do you see the same thing on this side as well as this side? It's the same, right? This one maybe doesn't have as much eosin in the whole system because even the glands are looking blue. So which is decidua? This Rupali said that the left hand side is decidua and the right hand side is pseudo decidua. Vandana, would you like to try? What? No? You don't want to take a guess. All right. Sheetal, you want to take a guess? Sheetal? Sheetal is not there. Okay. Simi?
Yes, ma'am. The left hand side is decidua, and the right hand side is probably pseudo decidua.
Why?
There is a difference in the number of glands in both these sections.
Oh, because there's a difference in the number of glands. Okay. You know,
Stroma is also edematous.
yeah. Actually, there's no such thing as pseudo-decidua. Okay. For something to be pseudo-decidua, it has to be that endometrium is not has not got does not have an implantation. It's only then that it becomes true decidua, right? Yeah. So on the left hand side, what you have is a very highly progestationalized endometrium, yeah, which may be transforming under the the effect of beta HCG into a decidua. On the right hand side, you have again a highly progestationalized endometrium, okay, in which the glands have become they look almost atrophic, but they are not. Okay, this is the effect of progesterone, a very high amount of progestation. That's all you can say, that this is highly, highly progestationalized, in which you have got, because decidua happens in the presence of progesterone and beta HCG. But if you have extraordinarily, and how does beta HCG decidualize the endometrium? It does it through the action of progesterone, because the placenta produces both estrogen and progesterone. Okay, so I can't tell the difference between one or the other, and therefore using these terms decidua or pseudo decidua without knowing whether the patient is pregnant or not is a hoax. Okay, now I know that the patient on the left hand side actually was pregnant, okay, early pregnancy. So I know that this is true decidua, okay, and therefore anything else which I know that there's no pregnancy, we should call pseudo decidua, but I never use these terms. If you don't know whether there is a pregnancy or not, you cannot use these terms, because progesterone by itself, whether it is produced in the body or given from without, will produce this picture. And this is an iatrogenically progestationalized endometrium on the right hand side. Okay, but if you don't know, you can suspect that there is a iatrogenically progestationalized endometrium. Then you have to call up the doctor and you have to ask, has this patient been given an injection of beta HCG, or has this patient been given exogenous progesterone by mouth or injection? So I don't like these terms. You know what decidua looks like, and this stroma is decidualized. Now, if the patient is pregnant, then it is true decidua. If the patient is not pregnant, it is pseudo decidua, but you don't take a guess as to whether this is or is not unless you know the pregnancy status of the patient. Okay. Now, I think we have already answered this question. Yes. Somebody told us, right? Decidua is derived from what? In the chat box, let people write. Endometrial glands, endometrial stroma, from pericytes, from the trophoblast or potential trophoblast.
Stroma.
Bullion, what is it?
Endometrium
Stroma.
Stroma. Excellent. Yes. So decidua is derived from endometrial stroma. Okay. And decidua expresses what? Pan-cytokeratin, that's A1, A3, SMA, EMA, Vimentin. Come on, Mullian. What does decidua express? Does it express pan-CK? Does it express EMA, that is epithelial membrane antigen? Does it express smooth muscle actin, which is SMA? Or does it express Vimentin? Come on,
It's
Mullian.
Vimentin.
Vimentin. Why? Why does it not express pan-cytokeratin?
It's a stromal system. Like it's not epithelium. So
it's stromal cells. Okay, very good. Why is it not a smooth muscle actin? All right, let me ask you.
Yes.
Julian, we have seen so many things. No? Smooth muscle actin would have been present in what? All of the different structures we have seen so far. We've seen glands, we have seen stroma, we have seen different structures that are present in the stroma, etc. So where would you expect to see smooth muscle actin? Julian,
In
you're
the
right.
biometrium.
It is vimentin, and you can see. Yes, where? In the
Biometrium.
myometrium. So far, I haven't shown you any myometrium, have I? No. So where would you expect to see smooth muscle actin? This is decidua. This is beautiful decidua here, and this is vimentin. Yeah. Now you saw something, no, Julian? You saw this, the spiral arterioles?
Yes,
So
ma'am.
should the spiral arterioles have smooth muscle actin?
Yes, ma'am.
Where will they be? Where will
Um,
that smooth muscle actin be?
In the wall of the arterioles.
Very good. What's in the wall of the arterioles? That will express smooth muscle actin. What is in the wall of the arteriole
Yes,
that will express smooth muscle?
tunica media has 1 or 2 layers of smooth muscle layer. Smooth muscle.
Huh? What? Yes, Julian. Come on, tell me.
Yes, ma'am.
You
tunica
know
media has
what an
1 or 2
arteriole,
layers of
what
smooth
an
muscle cells
arteriole
which
is,
express
right,
assembly.
Julian? What is an arteriole, Julian?
It's a small.
Yes, it's a small caliber blood vessel which
Blood vessels.
has what?
Smooth muscle layers in the tunica media, ma'am.
All vessels have smooth muscle in the tunica media. So what is special about the arteriole? Tunica media always will have smooth muscle, whether it's in the venule or it is in a vein or it is in an artery, small artery, large artery, aorta, anything. So what is it about the arteriole, Murian, that is special about the smooth muscle?
Collagen fiber, ma'am.
Sorry, 1 or 2 layers. I see. Murian, it is thick. For the size of that vessel, you have an extraordinarily thick, smooth muscle around that smooth muscle layer. That is what is an arteriole. Okay, it's all, you might even say that it is almost all smooth muscle with a very small lumen which is lined by endothelium. That is what is an arteriole. It is nothing but smooth muscle, many layers of smooth muscle with a thin, small lumen inside. That is an arteriole, Mulian. And if you really want to know about arterioles and the physiology of arterioles, please go and read it immediately tomorrow, okay? Because then you will understand why we need arterioles in our vascular system. It is that caliber blood vessel that is immediately before the capillary bed, and then find out why. All right, very good. Excellent. Now this is a menstrual phase, endometrium. And you can see that there is breakdown. All the glands are broken down. There is a lot of blood in this system. And you can just about make out that this is a menstrual phase endometrium, which has occurred after the secretory phase. This is not an anovulatory phase because you can see the nice secretory type glands without pseudo stratification of the the nuclei in these glands, and you can also see some amount of edema in between these the stromal cells. Okay, so this is a menstrual phase endometrium. And these are pregnancy associated changes. We've already discussed the decidua. You can see here this large pink cells with big nuclei, nucleoli, yes, and they look really large, but they are very different from the endometrial cells, which you can see endometrial glands, which you see over here. You see this single layer of cells. Really, they should be looking very tall and columnar, but once decidualization takes place, these endometrial glands actually can collapse and become very, very atrophic looking. They are not atrophied, but they look as if they are atrophied. And then you see other pregnancy associated changes, the most extreme of which you see in the right hand side corner, where the glands are actually look like their nuclei are showing some degree of anisocytosis. The chromatin is varying from one nucleus to another. And you see the same thing. This is a hyper of what you're seeing on the left-hand side. You see a large amount of secretion in the lumina. And this is what is called the Arya-Stella reaction. You don't see it that often because we don't get curettage from an endometrium very often, because these days everybody makes a diagnosis of an ectopic pregnancy and nobody actually curates the endometrium. So all those old things that are written in the textbooks that you can get very confused with carcinoma and all is very unlikely, because the ectopic pregnancy is in the tube and patients have already had the ultrasound, etc. Because any gynec symptom these days is investigated by an ultrasound. Okay, so these are the pictures that are not very commonly seen now. Now, this is a non-cycling atrophic post-menopausal endometrium. And I'm sure you now know by now what is the meaning of non-cycling. You see this? Here is the basalis. You can see the basalis layer, yeah, and you begin to see something else. This is obviously taken from a hysterectomy, and you see that there is an endometrial lining. Every endometrium towards the lumen must have a lining, okay? And the word endometrium does not mean glands alone. Endometrium is the lining. It is the stroma as well as the glands. And for all practical purposes, there is no functionalis over here. So it's a thin endometrium. And the other thing that you notice is that the endometrial myometrial junction is not very sharp. That is something that happens in an atrophic endometrium. And the reason is simple, that you get atrophy not just of the endometrium, you also get atrophy of the smooth muscle of the myometrium. And when smooth muscle of the myometrium gets atrophied, it begins to get small and blue, and you can't see the distinction between the small blue stroma of the endometrium and the atrophied cells of the myometrium, which also shrink, and you no longer see the nice fleshy pink cytoplasm of the cell. Now, something else that can happen in an atrophic endometrium is that it can become extremely cystic. And this is not cystic hyperplasia, this is cystic atrophy. So both hyperplasia and atrophy can show you cystic change. The difference is that in cystic atrophy, the endometrial lining epithelium is very, very thin. In cystic hyperplasia, the endometrial lining is plump. The cells are plump. It is not flattened out. Okay. So now we have to get to endometrial sampling. How do you sample the endometrium? Okay. Endometrial sampling can be done by a variety of ways. One of them is what we call an office procedure. That means you can do it in a clinic. The gynecologist in his or her clinic can do this. And this is what is called a pipelle biopsy. It's a small little tubular instrument which you put into the cervix without dilatation. and you suck out a little bit of the endometrium. And it should contain only the superficial endometrial lining and a very superficial part of the functionalis. That's about all that you can get in a pipette biopsy. All right. The next thing is what we are most familiar with, and that is curettage and dilatation of the cervix. We call it, it should be dilatation and curettage, but you get the curettage after you have dilated the cervix. You cannot put in a curette without dilatation of the cervix because the patient will go into shock. To try to dilate, to push something in through the cervix, which is a thickish curette, requires anesthesia and relaxation of the wall of the cervix, so that there is a lumen through which you can put the curette. So this is an operating room procedure under anesthesia of some kind. All right, it contains, in the curettage, you will get superficial endometrium, you will get a lot of the functionalis, and as I said before, it should not contain the basalis. That is what our standard curettage should contain. Then you have what is called the hysteroscopic, that under a hysteroscope. Of course, the patient has to have a dilatation of the cervix. So this cannot be done as an office procedure. It has to be done under anesthesia. And a hysteroscope, it's like a little scope that is put into the uterine cavity to get a view of the uterine cavity. It's an operating room procedure which is done under anesthesia, and this is called transcervical resection, because you're going to, just like you might do a bladder resection like TURP or a TURBT, that's bladder tumor. You do this, you curette out the tumor under not the tumor, the endometrium under direct vision. Okay, it is not performed, and this is very important, if fertility is to be maintained. Why? Because quite often, along with this the endometrium comes a portion of the myometrium. So it is done only if you are wanting to do a hysterectomy later on and you want to find out if there is any abnormality there that might be malignant, or it might have in situ carcinoma or in situ neoplasia, and you're anyway going to do a hysterectomy, or you're going to do it for abnormal bleeding or fibroids, then and then only you will do this hysteroscopic transcervical resection of the endometrium, because it will contain the superficial lining, it will contain the functionalis, it will contain most often the basalis and some portions of the superficial myometrium. Okay, so this is the time when you will be able to see the basalis in your curettage. If you've got a standard curettage, you will not see, or you should not see, the basalis. All right. Now, whenever you're doing this, what are the indications? And the indications are abnormal uterine bleeding during reproductive life, unexplained amenorrhea of some duration, and you're suspecting that there may be tuberculosis or some other reason for why this patient doesn't have her periods. Postmenopausal bleeding, of course, in postmenopausal bleeding, after ultrasound examination, if you have a thick endometrium or there's some other reason you want to do a curettage, then you can do it. If on USG findings, you have a thickened endometrium or a polyp on some kind of routine scan, missed abortion, bleeding after evacuation of products of conception, evaluating the effects of hormonal or other treatments. And you see that the last thing that I've put there, and I have got an arrow pointing to it. Nobody today does an endometrial curettage biopsy or any other form of endometrial sampling to date the endometrium. It does not happen. Today, all the dating of the endometrium used to be done to know whether there was ovulation or anovulation or whatever. All of that is now done by ultrasound. So if somebody is sending you this for dating, you have to ask, why is this being done? Okay. And what is the important history? You need to know the age of the patient, because obviously if the patient is 70 years old, you cannot talk about a cycling endometrium. Right? You need the height and the weight. Why do you need the height and the weight? Because patients who are obese, I'm sure that several of you, all of you know that the peripheral fat converts a lot of the androstenone into estrogen. So those who are very obese can be producing a lot of estrogen from their fat. Okay, the menopausal status is important. Menstrual history: how long, when was the last menstrual period? How long is the bleeding time? Is this menorrhagia, hypomenorrhea? All those bits and pieces of information you require. If there has been a USG, then the USG findings. Has this patient been on any kind of hormonal treatment? And any other relevant history, chief amongst it being diabetes, hypertension, and what is the diet. Because a lot of patients nowadays they suffer from what is called the metabolic syndrome. And that is one of the reasons why so many young people are getting PCOS. That is polycystic ovarian disease, PCOS or PCOD, whatever way you want to call it. This is all part of the metabolic syndrome, which includes diabetes and hypertension. All right, what do you actually identify or should be looking for in an endometrial biopsy, curettage, or a TCR? Now here on the right-hand side is a TCR. Okay, so you've got a bit of the myometrium. This is one of the strips that has come out in a curettage under vision of a hysteroscope. So you see the entire thing from the endometrial lining, the functionalis, as well as the myometrium. So what should we be looking at? Adequacy. This is a very inadequate endometrium. Okay, and I don't think that anybody should be commenting on this endometrium except to say that it is inadequate. This often happens, in very elderly people with a very narrow cervix and somebody struggling to put a curette in, even though the patient is under anesthesia, and you get very little endometrium. You must mention the phase if it is cycling. All right, you cannot talk about the phase in a post-menopausal endometrium. You never talk about the phase if there is something that is not entirely benign. Then whatever abnormalities you see in a reproductive phase endometrium, abnormalities in an atrophic endometrium, we mentioned polyps if there are polyps, iatrogenic changes, if there is stuff that has been any kind of drugs or injectables that have been afforded to that patient, malignant change, if there is malignant change, and atypical change, but that's not something that I'm going to talk about much today. So now let us talk about endometrial proliferations. I won't get into this, but there is a FIGO grade, FIGO classification of causes of abnormal endometrial bleeding that the gynecologist would be interested in. But, there is something called PALM-Cohen, that is polyp, adenomyosis, leiomyoma, all of the causes of abnormal uterine bleeding, coagulopathy, ovulatory dysfunction, endometrial factors, okay, which have to do with abnormal uterine bleeding, which got nothing to do with ovulation, iatrogenic, as well as not otherwise. And so this is PALM and COEIN. So it's often called PALM-Cohen. And where are we pathologists not involved? We are not likely to see adenomyosis in a curettage. Okay, we will not know about coagulopathy, and this not otherwise classified is not within our realm. But these are the causes of abnormal uterine bleeding. Now, one of the most important causes of abnormal uterine bleeding is unopposed estrogen. Now, what is the meaning of this unopposed estrogen, Simi? What is this word? Unopposed, two words. What do they mean? Simi, you there?
Yes, ma'am.
Yeah, so what is the meaning of unopposed estrogen?
Then, ma'am, there is only the effect of estrogen is there on the endometrium, and there is absence of or reduced amount of progesterone.
Yeah, so that means that between one menstrual cycle and the next round of bleeding, or between two menstrual cycles when there is bleeding, there has been just estrogen acting on the endometrium. Okay, normally we expect that you have estrogen, and then estrogen is followed by progesterone, and that is what we call opposition. Okay, so estrogen is opposed by progesterone. And what do we mean by opposed? I told you that as soon as progesterone comes into the system, estrogen, the effect of estrogen is cancelled out. So estrogen is opposed by progesterone. And what is that effect that is cancelled out, Simi?
Proliferation stops.
Proliferation stops. So progesterone acts in opposition to estrogen. Now, this is a very common word, and we should be thinking of the endometrium in these terms. Estrogen opposed by progesterone, and that is what happens in the normal ovulatory cycle, right? If you have estrogen unopposed by progesterone, so estrogen is running around completely unopposed, then you get abnormal uterine bleeding. One of the causes of, or one of the more common causes of abnormal uterine bleeding, in which you get abnormalities in endometrial proliferation, is unopposed estrogen activity. Okay, now first thing that happens is that the endometrium becomes disordered. Now, what do we mean by disordered? You saw what a normal endometrium in the proliferative phase was. Okay, it's got nice round gland. See, in fact, you see that curvature of the glands and some pseudo branching that occurs in the secretory phase, because the glands are now getting corkscrew like. Here, normally you see just nice round glands set in a stroma, depending upon how late in the proliferative phase it is, you get more or less glands and more or less space between the glands. But now see what happens if you have estrogen acting for longer than the normal time period for which estrogen should act on the endometrium. And you see this? You see very abnormal curvatures and what looks like branching, etc. You can actually, a lot of it in some places really looks like basal endometrium. Okay, but it isn't basal endometrium. This is endometrium, which has really been acting on the endometrium. Maybe a lot of endometrium, or it may be some endometrium, estrogen, but it is unopposed by progesterone. So this is called disordered proliferation. Then you get simple hypoplasia. Actually, sometimes you can't tell the difference between disordered proliferation and simple hypoplasia with cysts. And this is what you see. Sometimes you see some tubal change. In other words, you see a little, cilia. You get some other kinds of metaplasia. Sometimes it's squamous metaplasia. You see fibrin thrombi, and you see breakdown. Because what is happening is that this endometrium is constantly, there are fluctuating levels of estrogen that are coming from the follicles in the ovary, and with those fluctuating levels, you get a little bleeding now and then, and therefore you will get these fibrin thrombi inside the vessels. Remember, there are no spiral arterioles. If this goes on for longer periods, over 20 days, 25 days, etc., before bleeding starts, you can get atypical hyperplasia, which I think is synonymous with endometrial intraepithelial neoplasia, also known as EIN. Or if it goes on for even longer, then it can transform into a well-differentiated endometrial carcinoma. So one thing is certain, from here to here, it's all estrogen. There is nothing else but estrogen in the system, and it is estrogen that causes proliferation. It leads to all of these different kinds of proliferation, all the way up to well-differentiated endometrial carcinoma. So well-differentiated endometrial carcinoma is also effect of unopposed estrogen acting for a long time on the endometrium. Now, where that estrogen is coming from, whether it is a powerful estrogen that is coming from the ovary, and that that the estrogen that comes from the ovary is estradiol. All right, the endometrium that comes from the fat, which is where in an obese individual, particularly in a post-menopausal obese individual, is estrone. And estrone is a very, very weak estrogen. Its effects are extremely weak. But that weak estrogen acting continuously on that endometrium, particularly in a postmenopausal woman. There's no estradiol because the ovary is, this is postmenopausal. For a long period of time can lead to all of these effects, including well-differentiated endometrial carcinoma. Okay, and of course, patients quite often have a metabolic syndrome as well, with diabetes, hypertension, and other things. So this is what unopposed estrogen looks like. Okay, here you have some more pictures. This is disordered proliferation. You see this with little branching glands. You got some normal rounded glands, but normal endometrial proliferation doesn't show you this very branching, irregular type glands. All right. There is not much difference between disordered proliferation and simple hyperplasia, non-atypical hyperplasia as it is often called. Now, you may use one or the other term. I like this term disordered proliferation, but if somebody wants to call it hyperplasia and non-atypical hyperplasia, they are quite welcome to do that. You get much more cystic change in simple hyperplasia, which is non-atypical. But now when you get to atypical hyperplasia or endometrial intraepithelial neoplasia, notice that here you are actually getting glands that are close to one another. Yeah, there is very little space between the glands. You are seeing this pseudo stratification of the nuclei. You may actually see actual stratification of the cells, and there is, compared to what you're seeing there is atypia that is seen in this in the cells. remember one thing, that all of this is acted upon by estrogen. Okay, so all of these are estrogenized. It is just the degree to which estrogen has acted on this and the length for which estrogen has acted on this endometrium and how the endometrium has responded to this unopposed estrogen. Okay, so we have disordered proliferation, we have simple hyperplasia, we have atypical hyperplasia. Now I'm going to show you a case, all right? And I want you to tell me what you think about this endometrium. Here is a 51-year-old woman, average height and weight. She's non-diabetic, non-hypertensive. She had a last menstrual period 45 days ago with intermittent, and she had intermittent spotting. So in between a full-fledged bleeding, she had intermittent spotting. And the ultrasound showed a 9 millimeter thick endometrium. Okay, so now one of you will have to describe to me quickly this endometrium and tell me what do you think you will call this endometrium. Who would like to take this this thing? Rupali, come on.
Yes, ma'am.
Tell me how you
In
will describe this endometrium and what diagnosis you will give.
First slide, the section
They're all
shows
from her
the
same. They're all from the different parts of her endometrium. So you don't have to describe first slide, second slide, third slide. Just look at it. Quickly tell me what you are seeing and what you are going to diagnose this as.
there is a endometrial lining. Then the endometrial glands are dilated and branched.
Yes.
With stroma.
With stroma, all endometria have got stroma.
Yes,
so what do you want to say?
Yes. So it is the disorder proliferative endometrium.
Okay, so you're right. So this is a disordered proliferation, and if at the most you want to call it non-atypical, that means this is a simple hyperplasia or non-atypical hyperplasia. Yes. So now you tell me, why does she have this endometrium like this? She's not obese, average height and weight. She's 51. She's non-diabetic. She doesn't have a metabolic syndrome. Okay. So.
Yes.
So tell me, why?
Perimenopausal.
Perimenopausal, excellent. So if you had to explain to somebody why this endometrium is the way that it is, okay, why is it? What has acted on this endometrium and what has not acted on this endometrium? What hormone is acting? There are only two hormones we're talking about, no? Estrogen and progesterone. So tell me, what has acted, what has not acted?
Estrogen is active.
Huh?
And then
very good.
Estrogen is active. And
excellent.
There is no progesterone.
Exactly. And there is no progesterone. So this is unopposed estrogen activity on the endometrium, right? So, and because it is unopposed estrogen activity, so if you had to write this report, it is unopposed estrogen activity, which is giving rise to what? Disordered proliferation or simple hyperplasia, whatever you want to, call it. It is not EIN, correct? So this, yes, and this woman, if she's allowed to go into menopause on her own, she would probably be all right. But now she's getting spotting, and she's had a very 45 days, a menstrual cycle of 45 days in this. So this is disordered endometrial proliferation, which is an endometrium that is estrogenized, and it is unopposed estrogen that has acted on this endometrium. Excellent. That's very good, Rupali. All right. Now, come on. Who else will want to take this? Vandana, come on. Are you there, Vandana? Vandana
Yes,
is not there. She's there? Ah, very good, Vandana. Say yes at least so that I know you're there. Otherwise, I think you have disappeared. Come on, Vandana.
ma'am.
Here is a patient. 48-year-old female with recent heavy periods. She's had a hysterectomy without a prior DNC, and this is the hysterectomy. Chalo. Vandana, are you going to do something or you're not going to? All right, I don't think Vandana is there. Come on, Sheetal. Are you there, Sheetal? Sheetal is also disappeared. Okay. Mulian?
Ma'am, here is
Yes,
back to back of
Who
glands.
is this? Vandana?
Yes, ma'am. Yes,
Ah,
me.
come on then. Come on,
Ma'am,
Vandana.
my internet is got disrupted again and again due to rainfall.
All right, now come on. Now it is not disrupted. Come on.
Yes.
Ah.
There is back to back arrangement of glands.
Where is that? Back to back arrangement of glands. You want to ask for annotation?
Ma'am, I'm connecting with my mobile, so I can't.
Oh, you're okay. All right, fine. So instead of you, come on, somebody else take this. Sheetal? Are you there, Sheetal? No, Sheetal is not there. All right, Mulian?
Cystically dilated.
Mulian, are you there? Mulian
Yes,
has
ma'am.
also disappeared.
Yes, ma'am.
Very good. Chalo, Mulian. Come on. She said there is back-to-back arrangement of the glands. Can you see that?
Yes, ma'am. We have that back-to-back arrangement in the second picture, ma'am,
Okay.
and some dilated glands.
All right. What do you see in the first picture?
The first picture, there is a increase in stromal to glands ratio.
Increase in stromal to gland ratio. In the first picture, Mulian, what do you see? Do you see the same picture, right? The same appearance right throughout this first picture? Is that right? Huh, Mulian?
No.
No?
One focus showing back-to-back glands and another focus showing fully dilated glands.
All right. And is there a third focus or there are no only two foci? Come on, Mulian. Huh? Am I sort of am I misunderstanding this thing? What, Mulian? You can't see that there are three different parts of this endometrium. Can you see that or you can't? One part is here.
Three
Yes.
different parts.
Are there three or not, Mulian? Mulian, can you hear me? Just say
Yes,
yes.
ma'am. Yes.
Oh, yes. That is one part that is bounded by blue. Here is another part that's bounded by my white thing. Okay?
Yeah.
And then I have a third part. Do you see it or not?
Yes, ma'am. The basal is there.
What? That's a basal. What's wrong with you, Mulian? Which side do you think is the top of the endometrium? Oh, you think that this is the top of the endometrium? Yeah. No, certainly not. This is the top of the endometrium. So I've got one, I've got two, or three parts of this endometrium. Do you agree? Julian, do you agree? And that is what you can see. Here is this part. This is number 3.
Yes, ma'am.
This is number 1. Yes, and this is 3, and this is number 2. So what are you seeing, Julian? Come on. No, Boolean is, cannot say it. Come on, Sheetal is not there. Simi, come on. What is 1, 2, and 3?
First one has a back-to-back arrangement of glands.
First
And,
one meaning I've got number 1, number 2, number 3. So please, if you're wanting to say, please use the numbering.
And then the number 3 has back-to-back arrangement of glands, and there is also stratification, and nuclear ATPI is also there.
Okay.
Number 2 is has cystically dilated glands.
Okay.
And number 3 looks like a disordered proliferative endometrium.
Well, it's like maybe disordered proliferation, but it is estrogenized, yeah. And you can see how this looks like. This is not the back-to-back wala, no. So this is what it looks like. And actually, if you look at it, this is what ordinary proliferative endometrium looks like, you know, round glands, etc. Yeah, there is some degree of branching, so there is some disordered proliferation. So really, what is happening over here, Simi, in this case? What is going on over here? You can see, tell me in terms of physiology, what is going on in this endometrium?
Patient is having the changes of endometrium, they're depending upon the amount of estrogen she is exposed to.
Okay. So has she got any progesterone in the system? Has she got any progesterone in the system? Come on, Simi.
Sure about that.
You're not sure about it. Acha. Okay.
It's
Nargis.
usually unopposed estrogen.
Nargis, is there any progesterone that has acted on this endometrium? Nargis, you're there, right?
Yes, ma'am.
So is there has there been any progesterone that has acted on this endometrium?
No, ma'am.
No, ma'am. Absolutely. So what is happened to this endometrium? Lots of people are writing about it in the chat box. What has happened? That there has been continuous unopposed estrogen activity on this stimulation of this endometrium. Do you agree, Nargis?
Yes, ma'am.
Yes. So, Simi, you could not say, I'm not sure, ma'am. There is absolutely no progesterone that has acted on this endometrium. If there had been progesterone acting on this endometrium, what would you have expected to see, Simi? Simi, are you there, Simi?
Yes, ma'am.
What would you have expected to see if there had been progesterone in this endometrium?
Differentiation would have started.
So don't give me these big words. How would I know that there was differentiation? How would I know?
There'll be presence of spiral arterioles in this, and
Really? Simi, I know it's late and you're hungry. What is the first thing that happens when you have progesterone in a system? Simi? No, Simi doesn't know. Sheetal is not there. Rupali, what's the first thing that happens when progesterone comes into a system?
There is no mitosis seen.
There is no proliferation. Proliferation is shut off. Can you see proliferation in the system, Rupali?
Yes, ma'am.
Yes. How do you know that there's proliferation? How do you know that there's proliferation? You're very right. But how do you know that proliferation
The gland
is shut
shows
off?
the mitosis.
Oh, there's
Glands.
mitosis. There's one big fat mitosis right here. Can you see it where
Yes, ma'am.
my cursor is?
Yes, ma'am.
You cannot get back-to-back
Yes, ma'am.
glands, and you cannot get these cystic changes in the endometrium. Yeah, there is everything is screaming at you that this is unopposed estrogen. There has been no progesterone in this system. Simi, do you get it?
Yes, ma'am.
Yeah, you can see the mitosis or you can't. Yeah, there is a mitosis right there sitting in the right hand side bottom picture. Can you see the mitosis or not?
Yes.
Yes. So please get out of the set habit that all of you have. Set habits. I must see secretion. I must see spiral arterioles. I must see subnuclear vacuolation. No, the first thing I should make sure is that there is no proliferation, there are no mitoses. Okay, then look for everything else. Okay, the fact that you have nice columnar cells, that there is no nuclear pseudo stratification of the nuclei, that you can't, then you begin to see the secretions in the glands, and then you look for spiral arterioles. This is unopposed estrogen activity, okay? And it is gone from, you can see over here on the bottom left-hand corner, you can see simple hyperplasia, you can call it disordered proliferation. So right here in the first thing, all three are seen together. You've got disordered proliferation, simple non-atypical hyperplasia, and EIN. Agreed, everybody? If there's anybody who has any problem about this, please say, I do not agree. Okay, and you can see this. I've just shown it over here. You have proliferative endometrium, or with simple hyperplasia, whatever you want to call it. And then you have atypical hyperplasia. And you can see the way that this has happened in this one single endometrium. And if you ask me, and I can ask you, and you'll have to think about it, how come in the same endometrium you can get three different pictures? It's the same amount of estrogen, right? So why is this showing you three different pictures in the same endometrium? Think about it, and we will discuss this later if we have the chance. Okay, so now we have some classifications, and people discuss these, or classify them in different ways. The old WHO classification was simple hyperplasia without atypia, complex hyperplasia, and so on, and simple atypical hyperplasia, complex atypical hyperplasia. And then, of course, it all changed. The EIN classification was gland versus stroma ratio, cytology versus normal glands in the vicinity, normal glands in the vicinity. There had to be a minimum size of greater than 5 millimeters in a single tissue fragment, and so on and so forth. I don't think that it is terribly important for you to know all these definitions, okay? And I'm not going to go into these charts because but this is the WHO classification which is being used. It was devised in 2014, remains more or less the same in 2018. And this is it's hyperplasia without atypia. It's called non-atypical hyperplasia, if you wish. As I said, some people don't use the term disordered proliferation. I like to use the term because I feel that that's the proliferation without the cystic change. But you can, sort of use any term you want as long as you say that it is hyperplasia without atypia. Okay, and there are all kinds of synonyms that have been given. And are there any genetic changes? There are very low levels of somatic mutations in scattered glands. Okay, and I think the morphology on H&E staining shows no specific changes in the areas with the genetic change, if there is any. Can there be coexistent carcinoma? Yes, there can be coexistent carcinoma. And by carcinoma, what do we mean? Not atypical hyperplasia or endometrial intraepithelial neoplasia. It means carcinoma that is invading the myometrium. So you need to see myometrial invasion to call something a carcinoma. Okay? So very, very low incidence of coexistent carcinoma. But when you start to get atypical hyperplasia, okay, it is endometrioid intraepithelial neoplasia. It is any hyperplasia with atypia, also called endometrioid intraepithelial neoplasia or endometrial intraepithelial neoplasia. And then you have genetic changes that are typical for endometrioid carcinoma, that is well-differentiated endometrioid carcinoma, are present. And these are some of the genetic changes. And you had a beautiful talk on the genetic changes in endometrial carcinomas of all kinds. That was, last week. And I think that those of you who haven't seen that recording, if it's still up there, I think you should see that particular thing, because it was a really very nice session that you had, where both Dr. Alina D'Souza as well as Dr. Divya Midha showed you cases and gave you this concepts on what these genetic changes, etc., are. Now, there is you get coexisting invasive carcinoma in greater than 25% of this, or 25 to 59%. And this is the progression to carcinoma. That's the relative risk is 14 to 45%. So this is what, are simple terms that you can use, and they are acceptable for the WHO. Now, here is another case. Okay, it's a 62-year-old woman who was married. Well, she's not married for, yeah, she is. She's been married for 42 years. Okay, so she was 20 years old when she got, was being investigated for post-menopausal bleeding. I don't know why there is married for 42 years, but anyway, she's diabetic, she's overweight, and the ultrasound shows a thickened endometrium. All right, so Nargis, now tell me. Come on, Nargis, you're there?
Yes, ma'am.
Very good. Now tell me. See, we have been talking now, when you look at an endometrium, you have to think of that endometrium as being the target of hormones. And the only two hormones that we need to think about are what, Nargis? What are the two hormones that we need to think about that act on the endometrium? What are the two hormones, Nargis?
Estrogen and progesterone.
Fantastic. So we only need to think about these two hormones. Excellent. Now, look at this picture, Nargis, and tell me which of these two hormones have acted on this endometrium. Just do that. Let's not, get into all kinds of what is the diagnosis and all this. Which of these hormones, or both, whichever, have acted on this endometrium? You've got two fairly low power pictures and you've got two high power pictures. That's all I want to know, Nargis.
Oh, ma'am, estrogen.
Okay, so estrogen has acted. Anything else has acted? Go on, Nargis. Huh? What has acted on this endometrium? You said estrogen. Good. Has anything else acted on this endometrium? It's a yes or no question, Nargis. Has anything else acted on this endometrium? Yes or no? Where are you, Nargis? Have you disappeared?
Yes, ma'am.
So, what is the answer to my second question? Has anything else? You said that estrogen has acted on it. Very good. Has any other, has progesterone acted on this endometrium? There are only two hormones, okay? Has progesterone acted on this endometrium? Yes or no? Come on, Nargis. Yes or no? All right. You want to think? Think. Vandana. Answer the second question. What do you think, that there's no progesterone, that's no estrogen that's acted on this endometrium? What do you think, Vandana? What has
Unopposed
acted?
estrogen.
Sorry?
There is unopposed estrogen.
There's estrogen that's acted. Very good, Vandana. Is there any progesterone that has acted? Vandana,
No,
that's
ma'am.
my second
I think
question,
so.
no? Huh?
No, I think so. No.
What do you think, Vandana?
Ma'am, no progesterone, only
No
estrogen.
progesterone has acted on this endometrium. Now, Nargis, Vandana says no progesterone. Do you agree with her?
Yes, ma'am.
Then why did you not say it, Nargis? Huh? What was your confusion? Because if you have a confusion, there are a lot of people in the audience who are not there who also have the confusion. So please tell me, what was your confusion? Why could you not state like Vandana straight away? This is only estrogen and there's no progesterone. What was your confusion? Tell me. What was your confusion, Nargis? Because you only have two hormones. So it's either one, the other, or both. So you told me there was estrogen. Very good. Why did you think there was estrogen, Vandana? Sorry, Nargis. Why? You can't take a guess, Nargis. If you have said estrogen, you have to know why. Why? Why, Nargis? Or you're still very confused. And say, I'm confused, Nargis. Say openly, I'm confused. Are you confused? Yes? Are you confused?
Ma'am,
Do you understand the meaning of the word confused? Nargis, do you understand what
see
I'm asking you?
mitosis in the second slide.
You can see mitosis in the second slide. Yes. So what does that mean, Nargis?
Means, ma'am, proliferative endometrium.
So it means that this endometrium is
Estrogen
proliferating. Very good. Which means what? What has acted on
Estrogen.
this endometrium? Estrogen. If there is proliferation, if you are seeing mitosis, has progesterone acted on this endometrium? What happens
No,
when progesterone acts on the endometrium in which there has been estrogen? What's the first thing that happens, Nargis?
Absence of mitosis.
Absence of mitosis, yes. Why? Because progesterone switches off proliferation and starts the
Differentiation.
endometrium to differentiate. So if there is mitosis, and we saw it in the previous case, Nargis, if there are mitoses, and there are so many mitoses here, you can see them. You can see in the first picture, Nargis. Vandana, am I right in what I'm saying? Is that
Yes,
why
ma'am.
you thought that there was no progesterone?
Yes, ma'am.
Right. So will you explain to everybody, Vandana, instead of me explaining, why did you think that there was only estrogen in this system?
Because here is mitosis and proliferation of glands occur. Much more proliferating glands are seen in these pictures and mitosis also.
No, so there is mitosis. So there can
Yes.
have been no progesterone. So what is this endometrium? Now, how will you describe this endometrium now? What are you seeing in the first picture? What we just talked about, no? There are two, then the WHO, you have only two things, right?
Ma'am, glands to stroma ratio is increased.
Yes.
Predominance of glands.
Yes.
In the second
first
picture, there
what
is
will you call it? This is an estrogenized endometrium. Absolutely. And it is unopposed by progesterone. Agreed?
Yes, ma'am.
Very good. And now you're seeing estrogenized proliferating glands with the gland to stroma ratio being in favor of the glands, yes, and you're seeing branching glands and you're seeing dilated glands and you're seeing the same thing in the second picture on the lower left hand side. So what would you want to call this side of the picture, Vandana? Do you think it's normal proliferative phase, Vandana? Because that is estrogen, right?
Yes, ma'am. But it's not normal. It's
It's not
hyperplasia.
normal. Excellent. So what is it there?
Ma'am,
It's
because
not-
complex pattern of proliferating glands is seen here.
Excellent. So then what is it? What is it? If you had to choose between this and this, which would you choose for the pictures on the left-hand
Atypical
side?
hyperplasia. I will choose atypical hyperplasia.
Really? On the left-hand side, this is atypical hyperplasia? Since when?
No, ma'am, not.
If
In
you tell
fourth,
me that here and here it is atypical hyperplasia on the right-hand side, I would
no,
agree.
ma'am, in left hand pictures, left hand side picture.
So this is atypical hyperplasia. Why? Why?
No, ma'am,
This is
here only
atypical
hyperplasia.
hyperplasia. On the right-hand side, it is atypical hyperplasia. On the left-hand side, what is it? Huh? What, Vandana? Rupali, what did you say? Are you there, Rupali?
Yes, ma'am.
So tell me.
Ma'am,
Can't hear you, Rupali.
hyperplasia without atypia.
So what do you see on the left-hand side, on both sides? This is?
Ma'am, hyperplasia without
Without
atypia.
atypia. And what's on the right-hand side?
Ma'am, back-to-back arranged
Yeah, so
glands
then
with
this
no
is?
stroma.
So
Uh,
this is
This is
atypical
also
hyperplasia or endometrioid in situ neoplasia, right? What? What's your
yes,
problem
ma'am.
now? What's your problem, Rupali? You think
Nuclear
this is also,
atypia
do
is
you think that this has got atypia or no atypia? On the right-hand side. Both the pictures on the right-hand side.
this is a hyperplasia without atypia.
Without atypia on the right-hand side. Arey, wah, great. Huh? Come on now, Mulian. Mulian, are you there? Mulian has disappeared. Okay. Simi.
Yes, ma'am.
Mulian
Left-hand
has
side is
appeared.
without atypia, ma'am.
Which is without atypia?
Can
On
you
the
hear me,
left
ma'am?
or the
Yes.
right?
Left-hand side is
Mulian? What? Mulian, left-hand side is what?
hyperplasia.
Right. And right-hand side?
Atypical.
I didn't hear you, Mulian. What is it? Say it loudly again. What is on the right-hand side? Is your internet bad, Mulian? Mulian, I can't hear you. The right-hand side is what? You know, this is the right-hand side. Can you see my cursor?
Atypical.
Atypical hyperplasia. Yeah, it is atypical. Look at the nuclei. Look at the. This is atypical. I don't know why people have any problem about calling this atypical hyperplasia. There is back to black gland. There is hardly any stroma in this thing, and there was. That's why I told you here. Okay, and how do you tell that it is that you have atypia? No, we have some reasons to call that atypical. And what is the atypia? The atypia is when you have, here it is, gland versus stroma ratio. Cytology has, you have to look at the cytology versus normal glands in the vicinity. Minimum size has to be greater than 5%. So now what else can this be? This is atypical hyperplasia, and this side, it is not atypical. This is what on the left-hand side is called hyperplasia without atypia. You can call it disordered proliferation, whatever. But here is atypical hyperplasia. But both these things are in the same endometrium. Okay. So if you have to describe this endometrium, you'll have to say, take the worst pattern that you see over here And the worst pattern is atypical hyperplasia. Okay. Now, so this is EIN or atypical hyperplasia that is seen in this particular woman. Okay. We don't know what is happening to her, whether this is invasive into her myometrium or not, because we do not have the myometrium to be seen. Now, what if I tell you that this is not a 62-year-old, but this is a 32-year-old woman? Okay, she's married for 2 years. She's being investigated for infertility. And the ultrasound again showed a thickened endometrium and her LMP was 40 days away. All right, now Simi, will you change your diagnosis?
Yes, ma'am, we could think in terms of proliferative endometrium.
So this is just a proliferative endometrium in this 32-year-old.
On the left side.
It is all the same endometrium. It's all in the same endometrium. It's just different parts of the same endometrium. So what are you going to say? Proliferative endometrium. Proliferative endometrium shows you all this branching and all that, Simi.
No, ma'am, there is certain amount of atypia in the sections on the right side.
I know that. So what is are you going to change your diagnosis, whether it is a 62-year-old or a 32-year-old? Are you? And the answer is no, it is still an atypical endometrial proliferation, which is driven by unopposed estrogen. Okay? In both these cases, it is indistinguishable from what? Atypical hyperplasia is indistinguishable from EIN. It is also indistinguishable from well-differentiated endometrial carcinoma. You will only know if this thing is a carcinoma if it is invading the myometrium. And we don't have the myometrium, right? So we don't know in this. In young women, many of these proliferations are reversible by appropriate hormonal manipulation. This is what we have to understand. But I don't care whether you guys understand the intricacies of this. Just understand one thing, that this is only estrogen that has acted on this endometrium. It is unopposed estrogen activity. This is all that you need to understand about the endometrium. Okay? Now, Simi, here is another patient, 40 years old, female, late marriage, long history of irregular periods with infrequent bouts of heavy bleeding. She never bothered about it until she got married and she wanted to conceive. And the ultrasound showed polycystic ovaries. And this is her thick endometrium. And there was no myometrial involvement on MRI. They do MRI to find out whether the myometrium is invaded. So now what are you going to say?
The patient has anovulatory cycles for a long period of time due to PCOD.
Yes. So
and there is definite unopposed estrogen effect.
Very good. It's an unopposed estrogen activity which is producing this very hyperplastic. It's a papillary hyperplasia. If this was an elderly woman, I would have said, she's got an endometrial carcinoma. But we don't want to make that diagnosis in this woman because she has got polycystic ovarian disease. Okay, so the same diagnosis is what one does. Okay, now you want to see something? I told you, it is reversible by appropriate hormonal manipulation. So she went on GnRH analogs and look at the same 40-year-old patient, endometrial biopsy 4 months after GnRH agonist therapy. So what has happened to her endometrium? The endometrium has now quietened down. Why did it get quietened down? Because what is GnRH, Simi? Gonadotropin releasing hormone. So now that gonadotropin releasing hormone is cut off. Yes. So then what happens? because you have cut off gonadotropin releasing hormone, then what happens, Simi?
FSH LH level decreases and
Exactly. So then what happens as a result of the FSH coming down?
Further the levels of estrogen come down.
What will happen to her polycystic ovaries? There will be no stimulation of the follicles in the ovary, no? Because what is FSH, Simi?
Follicular stimulating hormone.
Follicle stimulating hormone. So the follicle stimulating hormone is then shut off, and the follicles will not develop, the follicles will not produce estrogen, and the estrogen will not stimulate that endometrium like it had stimulated it before. Okay, so this woman now, from something that looks like a carcinoma of the endometrium, because it looks so hyperplastic, has now become completely quiescent. And we know that it is quiescent. This is a functional. You see the endometrial lining over there, and you see these round, nice proliferative phase glands. And it is the proliferative phase. Why? Why is it the proliferative phase, Simi?
The presence of mitosis in glands as well as stroma.
Yeah, absolutely. You can see the mitosis in the glands. Okay, there is no progesterone here. There cannot be progesterone. Why can there not be progesterone in me?
Because she is not developing corpus luteum.
Yeah, because the GnRH has stopped the pituitary from producing both FSH and LH, right? So there cannot be progesterone in this system. So this is a quiescent, early phase estrogenized endometrium. All right. Nargis, do you understand what we were talking about here? Yeah, Nargis? Is Nargis over there? Nargis? Nargis has disappeared? Okay. Rupali?
Yes, sir.
So is there progesterone in the system now, Rupali?
No, ma'am.
No. Why? Why?
There is no.
Why do you say there's no progesterone in the system?
There is no corpus luteum, and
It's
the
got
gland
nothing to
shows
do with the corpus
mitosis.
luteum. Look at this and tell me if there is any progesterone here. Then if
No,
progesterone
ma'am.
effect.
No, ma'am.
Why?
Because there is a mitosis and proliferating glands are seen.
Exactly. There are mitoses over here. Okay.
Yes,
So
ma'am.
this is proliferative phase endometrium, which is quiescent. Okay. There is some activity going on, but there is no progesterone in this system. Okay. Now, we just quickly finish with iatrogenic effects. You can get iatrogenic progestationalization. You can also get tamoxifen and lots of things that act on this endometrium. Here is a perimenopausal patient who is experiencing very heavy prolonged bleeding for the first time. She was given exogenous progesterone. Now you can tell that she must have had very dilated glands, yes, but there is progesterone in this system. How do we know that there is progesterone in the system?
No mitosis.
Because?
Vasodilation.
No mitosis or proliferating glands.
Proliferating glands? No, I can see decidualization.
No mitosis, ma'am.
No mitosis. Very good. Yes, no mitosis. Finally, everybody has got it. There is no mitosis, and look at the decidualization of the stroma. So this is iatrogenic progesterone acting on an endometrium, which shows simple disordered proliferation. All right. These are tamoxifen effects. I don't think that we should waste time on that. You have an endometrial polyp. Now, these polyps can occur in patients who have got atrophic endometria. They can occur in patients who have got hyperplastic endometria. But the important thing about the polyp is that most polyps show you what you can see over here. If there's anybody who's can see this, I can show it to you. You will see lots, you will see actually very thick walled blood vessels.
Blood vessels.
Yes, thick walled blood vessels are very typical of a polyp. You also see, now you see a polyp on the left hand side. Okay, now this polyp is in a perimenopausal woman, and you can see that three sides of this endometrium has got endometrial lining. See, you've got a little lining here, you've got a lining over there, you've got lining running around on this side. So it has to be that it is protruding from the endometrium. Okay, so this particular polyp is actually estrogenized. You can see that there is no progesterone in this particular polyp. So you look at it under high power, you will see that there are no mitotic figures. Now, this may not be very important for postgraduates, but for those who are practicing, you can see another form of endometrial in situ carcinoma. You know, we talked about endometrial intraepithelial neoplasia. That is an estrogen derived phenomenon. Over here, this is another term, and this is not EIN, this is EIC, and this is called endometrial in situ carcinoma. The endometrium looks fairly normal. You see some atypia in the glands, okay? But today, in this day and age, particularly in patients who are postmenopausal, all postmenopausal polyps, or for that matter, a postmenopausal endometrium, I make it a practice to do P53. And sometimes the most innocuous looking endometrium may suddenly show you block positivity for P53 and P16. You see, even the surface lining epithelium is expressing P53. This is a bad sign. Although there is no invasion of the myometrium, EIC, or endometrial in situ carcinoma, is actually related to the serous carcinoma of the endometrium. And sometimes, I mean, I have seen not many cases, but the patient seems to have no invasion of the myometrium, and yet there is lymph node metastasis. So this is something that you should remember, particularly those who are in practice. Try and get a P53 done on endometrium, particularly if you see some degree of nuclear atypia in a postmenopausal woman who otherwise seems to have an atrophic endometrium. And here is one of our cases. This was an endometrial polyp in a menopausal endometrium, and you are seeing atypia. But, you know, the glands are far apart. They are not crowded, but they look abnormal. And when you do a P53, you see that this is really a serous carcinoma of the endometrium, which shows you a great deal of P53, which you should not see in a benign endometrium. Okay, this had no invasion of the myometrium, so it's EIC. Now, we sometimes get frozen sections on endometrial curettage. Not many people do it, but in our practice, we see a lot of frozen sections, and this is the frozen section of an endometrial curettage. She has a 52-year-old woman, menopausal for a year, now has had a heavy period, and she had a very thickened endometrium, and you can see that there is squamous metaplasia over here. And then the problem was, this is just a curettage, okay? Is this atypical hyperplasia with squamous metaplasia, or is it the well-differentiated squamous carcinoma with squamous metaplasia? And it all depends on whether or not the myometrium has been invaded or not. Now, in this particular case, they should have done what was called a TCR, that is a trans-cervical resection, in which bits of the myometrium come, and then you would know whether it was invading the myometrium. This is the paraffin section showing you the squamous metaplasia very well. This patient actually had a well-differentiated carcinoma of the endometrium because it was invading the myometrium superficially. So it can be very difficult on a frozen section to say if you do not get the myometrium. In fact, it is very difficult on any curettage because there is no myometrium unless they are giving you a trans cervical resection, whether something is a EIN or a well-differentiated endometrial carcinoma. Okay. Oh, I forgot. This one had an AHEIN. It was not a thing. Okay. So how to report on any endometrial sampling? If it is scanty, you note the presence of endometrial or cervical tissue, mention that an opinion is limited by the scantiness. If it is premenopausal, then it's, you have to give the phase if it is benign and normal. In a cycling endometrium, please never talk about phase if the endometrium is not cycling. That means the patient must be having menstrual cycles. Whatever menstrual cycles, long or short, there should be a menstrual cycle. Okay. I told you that dating is more or less obsolete and replaced by ultrasound these days for monitoring the cycle. Abnormality, whatever abnormality, I like to state in terms of the hormonal action. If you look at the endometrium and think what has acted on this endometrium, you have very, very little chance to go wrong. Instead of learning all, oh, there should be gland in gland, oh, there should be secretions or this or that. Is there proliferation or not? And if there is no proliferation, has progesterone acted on this endometrium? Okay. So hormonal action, that is disordered proliferation, suggesting unopposed estrogen activity. And you mention any metaplasias if there are. Pregnancy associated changes, and I would avoid terms like pseudodecidua and pre-decidua, etc., and use terms degrees of progestationalization instead. And if there are iatrogenic effects, try to name the type of drug effect that you see. All right, now we have the last 3 or 4 cases, and I just want you people to answer these questions. Yes, very good. Come on now, who's there on my screen? I can see Simi. Simi, here is an endometrium. All right, and this is obviously a hysterectomy, and this is a section from the hysterectomy. Tell me, is this patient 18 years old, 35 years old, or 60 years old?
This is about like 60 years old.
60 years old. Very good. Simi is absolutely right. She's 60 years old. Why is she 60 years old, Simi?
There is senile cystic atrophy of the endometrium.
Yes, I understand. But why are you calling it cystic atrophy of the endometrium? And why are you not calling it cystic hyperplasia of the endometrium? There's cysts, yes. So why is it cystic atrophy and not cystic hyperplasia of the endometrium? Anybody else wants to answer? Yes, come on, Simi. Why?
Functionalis layer is not there.
Functionalis layer is not there. How do you know that there's no functionalis? I can see the endometrial lining, I can see these glands, and then of course I've got the bit of the basal layer here. So why are you saying that there's no functionalis? Why is this not cystic hyperplasia? You're right, but you could be right for the wrong reason, so I want to know the reason. Yeah?
See any mitosis in this?
Because of the mitosis. Come on now. Why? Even at this far, you don't need to see mitosis. Yeah, Rupali, why? She's right. It is 60. This patient is 60 years old. But why is this not cystic hyperplasia? Are you there, Rupali?
Yes, ma'am.
Yeah, tell me. And I don't need to look for mitosis. Vandana, come on.
Ma'am, here is inactive glands or dilated glands. seen over here, and no proliferation, no glandular and stromal proliferation is seen here.
No, the question is, yeah, no glandulars. See, look at the thickness of this endometrium. No, it's a thin endometrium. If there was hyperplasia, this endometrium would be thick. This is not a thick endometrium. All right, there are cystically dilated glands, but if this endometrium was hyperplastic, you would see a lot more glands and less stroma than you are seeing over here. So you're right, Simi, all of you are right, but you have to understand, you have to know why you're right. You can't just guess. Okay, it is not cystic hyperplasia, but because you would imagine that this would be so this endometrium would not be just from here to here, it would be very thick. So this is a post-menopausal atrophic endometrium. Very good. So now tell me, Vandana, is this low estrogen, high estrogen, or is there progesterone? Now that we know that this woman is 60 years old. Low estrogen, high estrogen, or progesterone here? Vandana?
No estrogen, ma'am. No estrogen.
Low estrogen. Yeah, there is never, every woman has estrogen till the day that she dies. Because if the estrogen is not coming from the ovaries, it is coming from other places. Okay, it's coming from a fat, it's coming from a, so don't say no estrogen, it is low estrogen. Very good. All right, so this is cystic atrophy of the endometrium. Now here, this is a cycling is this a cycling or a non-cycling endometrium? Rupali.
Non-cycling endometrium.
Rupali says non-cycling endometrium. Mulian, is this a cycling or a non-cycling endometrium?
Cycling.
I don't see anybody writing anything in the chat box. Yes. Yes, Mulian, what is it?
Cycling endometrium.
Why do you say that, Mulian?
Because I can see mitosis, ma'am, and proliferating glands.
You can see mitosis and the proliferating glands. Yeah?
Yes, ma'am.
Okay. This is cycling endometrium simply because I can see the endometrial lining. I can see nice round glands and I do not see the basalis over here. So I have only got functionalis in this thing. Where is the basalis? There's no basalis, and I showed you what the basalis look like. All right, and if you wanted to see what basalis looks like, here is the basalis. Can you see what basalis looks like in an atrophic? Because you will see nothing much but the basalis in a, and very little functionalis in an atrophic endometrium, right? Okay, so this, there is no basalis over here. This is a cycling endometrium. So now please tell me, Mulian, since you said cycling, is this low estrogen, high estrogen, progesterone, OC pill endometrium? What? How much, what is going on in this endometrium? Huh? Come on, Mulian.
It's okay, endometrium, because tubular glands with mitosis and some amount of hemorrhage and discoloration is there. So of the stroma is there.
So because of hemorrhage, it's a pill endometrium. Why?
No, restoration of the stroma.
Huh? What is the stroma? What?
Stromal discoloration with along with proliferating glands showing mitosis.
Oh, okay. So that's what he thinks. All right. Come on, Rupali. What do you think? Rupali, what do you think?
Ossipilli endometrium.
Ossipil. Acha, very good. Sheetal? Sheetal is not there. Simi?
Because of progesterone.
You think that there's progesterone? Really? Why, Simi? He just told you that this has got mitosis. I can see mitosis in this endometrium. So how can it be progesterone? Huh? There are very few glands in this particular thing and a lot of stroma. So if you have few glands and a lot of stroma, it cannot be progesterone, number one. It cannot be high estrogen, number two. Can it be? No, because if there was high estrogen in this thing, there would be lots of glands, right? So it cannot be a lot of estrogen. It cannot be progesterone. So you're left with either low estrogen or an OC pill endometrium. But in an OC pill, yeah, it could be an OC pill endometrium. But I know for one thing for certain, that there isn't a hell of a lot of estrogen in this thing, no? So this is a resting early proliferative endometrium. This is not what an OC pill endometrium looks like, because in an OC pill endometrium, both estrogen and progesterone are in the system together. And progesterone is in the system, it will not allow estrogen to act and make that endometrium proliferate. Okay, so it cannot be an OC pill endometrium. This is a low, early resting endometrium. All right, now tell me, what is this? Low estrogen, high estrogen, iatrogenic progesterone. Come on, Simi.
Iatrogenic progesterone.
Iatrogenic progesterone. Excellent. Yes, it is iatrogenic progesterone. Now, here is an endometrium. Low estrogen, high estrogen, there is progestationalization, and it is an OC pill endometrium.
High estrogen.
High estrogen. Yes, everybody's getting the picture. Okay, there's absolutely no progesterone in this system. Unopposed estrogen, which is simple hyperplasia. Okay, now tell me, Simi, an ovulatory cycle of 28 days, an ovulatory cycle of 36 days, 3 years post-menopausal, or any of the above.
Could be any of the above.
Yeah, why is it could be any of the above? And you're absolutely right. Why?
All three conditions have a high amount of estrogen.
All of them have, yes. So why 3 years more post-menopausal will have high amounts of estrogen? Post-menopausal doesn't have any estrogen. So why are you saying there's high amount of estrogen? Masimi, you are right. Any of the above. Somebody saying estrogen supplements. You think this patient is taking estrogen supplements? HRT? Possible.
It could be a possibility.
Yes. Any other possibility? What's the other possibility? Other possibilities? Oh, she's obese. If she's obese, her fat is making a lot of estrogen. Okay, so there can be endogenous or exogenous causes of post-menopausal high estrogen status. That means unopposed estrogen. And what are the endogenous causes? Obesity. Yes, there may be also, like you said in the beginning, an ovarian tumor. If there is an ovarian tumor, it could be producing a lot of, it could be producing estrogen, and the endometrium will look like this. What are the exogenous causes? Like somebody said, that this could be
hormone replacement therapy.
Yes, hormone replacement therapy. Or somebody is taking a lot of estrogens in the diet. And you get a lot of estrogen in the diet if somebody is a vegan and is having a lot of soya bean, etc. Soya is just full of what is called phytoestrogens. Okay, so there can be a lot of exogenous. You may not be taking estrogens from HRT, that's hormone replacement therapy. Excellent. All right. Now, if this patient is postmenopausal, is she 80 years old? We've already discussed this, obese, on blood thinners, or none of the above. What? She's obese. Yes. So if it was that, then she is absolutely unopposed estrogen activity. Now, here, who's going to answer this question? Nargis, are you there? Nargis has gone? Yeah, maybe Nargis has gone. Mulian, come on.
Yes.
What is this? Low estrogen, high estrogen, progesterone, OC pill. First of all, you tell me what is this blue looking gland over here? What is it?
It's
This very this on the you what I'm pointing out to? This one.
yes, ma'am.
Yes,
It's a
tell me.
dilated gland.
It is a what?
Dilated gland, ma'am.
It's a dilated gland. Okay, what is this? What gland is this? What is it? How would you describe this, Mulian? Somebody's already answered in the chat box and answered right. What does this gland look like to you? What is the shape, contour, etc. of this gland?
With the branching, ma'am, basal endometrium
It's
glands.
branching. So therefore it is
Basal
basalis.
endometrium.
Very good, Mulian. So this is basalis. Yeah, good. And what have you got here? So now that you can see this, what do you think? Here is your endometrial interface. Sorry, this is this endometrium. There's the basalis, and you can hardly see the interface with the myometrium. No, if this is basalis, where's the myometrium? It's there. Their myometrium is there,
Yes,
but
ma'am.
it is atrophic. So this is an atrophic endometrium, but this is not atrophy of the endometrium, is it? Mulian,
No,
this
the
doesn't look like atrophy.
back-to-back glands are there.
So you can see they're back-to-back glands, so it's not atrophy. So what is it? When do you get this kind of proliferation?
estrogen.
Proliferation. So what does it
High
mean?
estrogen.
High estrogen. Yes, and this means that this is a postmenopausal woman who has got a proliferative endometrium, obviously, because she has got estrogen from somewhere in her system. Maybe she's fat, maybe she's got an ovarian tumor, maybe she's got whatever. But what I want you people also to look at, see, this is endometrial stroma over here. See, I'm making little dots. That's the endometrial stroma, normal endometrial stroma between the basalis. And where is the myometrium? See, this is myometrium. And you never believe that this is myometrium, but it is. And the atrophic myometrium, that's what it looks like. And therefore, it is what happens to the myometrium. It starts looking like endometrium. And if you're not careful, you will think that something is invading it's not invading the myometrium because you are unable to tell the line between the myometrium and the endometrium. Okay, so these are some of the problems that you have in this. So the answer to this question is that it is high endometrium. Okay, so is this 36-year-old with PCOD, 56-year-old on HRT? Is it 40-year-old obese, or all of the above? What do you think? All of the above.
All of the above.
Oh, yes, it could be any of these, but I am telling you, it could be any, but this is actually a 56-year-old who's on HRT, and she has developed an endometrial carcinoma. All right, unopposed estrogen, AH or EIN. All right, now the last thing about how to report an endometrial sampling in a premenopausal woman, and we have looked at all of that. You talk about disordered proliferation, cystic hyperplasia, use the WHO 2014 or 18, okay? In young women, we have talked about atypical proliferation, indistinguishable from this, and comment that it is usually driven by unopposed estrogen, may revert with appropriate hormonal manipulation. Polyps, you are unusual in premenopausal women. And of course, you may get endometritis. And if you have mesenchymal lesions, one thing I will tell you, do not grade smooth muscle tumors in an endometrial curettage as ever. Okay, now this is an endometrium in a postmenopausal woman. What do you want to say about this? Simi? This is an endometrial curettage in a post-menopausal woman. What?
This could be atypical hyperplasia.
Atypical hyperplasia. Why is it atypical? Do you see back-to-back? Gland to stromal
There's
ratio?
some stratification in the glands.
Stratification doesn't mean atypia. Is this back-to-back? No. So why are we calling it atypical? Huh? What did I say that in an endometrium in a postmenopausal woman we should do? We should do P53.
P53, yes.
And there you are, block positive of P53. This is endometrial in situ carcinoma. Very important to think about in a postmenopausal woman, particularly if you start seeing some atypia in the gland. So this is not atypical hyperplasia. It is do the P53 and figure this out. Here is another endometrium in a postmenopausal woman. So what are you seeing in this first picture? Mulian or anybody, Rupali, what's seen in this first picture? What? What is in the first picture? Come on now. No? First picture, second picture, atrophic endometrium. You can see there is no functionalis over there. Okay, and these are the glands at high power. In the next picture, you have got atypical hyperplasia or EIN. See the back-to-back, which you didn't see in the previous thing. Okay, and then you did the P53 and you see it is wild type. What is the meaning of wild type? It means that every cell over there does not express the P53. You see that there are some cells that are expressing it as little brown dots, and the majority of them are not. Okay, so this is atypical hyperplasia, EIN. The P53 is wild type expression. So in postmenopausal women, please beware that EIC, which is a serous carcinoma, is often you do not suspect it, and it is there in an atrophic endometrium. Today we have fortunately P53, and this P53 staining should be deployed if possible. One thing you should not do is use the term phase in a postmenopausal woman, because there is no phase over there. There may be a proliferative endometrium, but it is not in the proliferative phase. If there is a proliferative endometrium in a postmenopausal woman, it is because, Simi, why? Can you get a proliferative endometrium in a postmenopausal woman? Yes or no?
Yes, ma'am.
Yes, you can. Very good. Who sent that? Rupali? Or
Vandana.
Vandana. Why do you get a proliferative endometrium in a postmenopausal woman?
Estrogen.
Because of estrogen activity. Very good. And that estrogen activity can be, I've written it over here, no? Exogenous or endogenous. And exogenous is HRT, dietary, phytoestrogens. Endogenous is obesity, ovarian stromal tumor, or otherwise. Okay? So that's the end of my talk, and thank you very much. You guys have been very interactive, and I'm very happy that to have had you people here today. Okay, good.
Thank you.
So thank you very much. I don't think that there will be too many questions because it's very late, but there was some question that I saw over there, which was something to do with polyps. A polyp. Oh, no, sorry. How do we know or something about, can you get a non-myo-invasive carcinoma? There was a question over there, right? If
What is non-myoinvasive endometrial carcinoma in a hysterectomy specimen?
what is non-myoinvasive endometrial carcinoma in a hysterectomy? Yeah, and I just showed you some, no? And these are EICs. EIC is a non-myoinvasive endometrial carcinoma. It's there. It's not infiltrating the myometrium, but it has the potential to actually go to lymph nodes. If you have a well-differentiated endometrial carcinoma, which is always estrogen-driven, which is indistinguishable from EIN, if you just look at the glands, for that to be a carcinoma, it has to be invading the myometrium, okay? But non-myoinvasive endometrial carcinoma is EIC. So does that answer the question? Okay, are there any other questions? I'm sure that most people have been answering my questions in the chat box, right?
Yes, ma'am. Yeah.
Now that's good. Okay,
Yes.
I see one Dr. Sunil who's fast asleep. Can you see him?
Yes.
He's there on my screen and he's fast asleep. I'm very sorry, Dr. Sunil, that I put you to sleep, but I hope that there are some people who stayed awake, okay, to listen to my talk on the endometrium. Don't worry about it. If he's asleep, he's asleep. Not to worry. Okay. If there are any questions that anybody now wants to ask, I'm happy to. But you have to please think of the endometrium as a target organ, which I am sure that none of the postgraduates and very few of the practicing pathologists ever think of the endometrium as a target organ. Okay, most postgraduates mug up pictures from what they have seen in the textbooks and what are written in the textbooks. Okay, and what are those pictures? Oh, they will have these glands and so much stroma, and there will be edema in the stroma, and there will be this and that and the other, and gland appearance. It is so simple. Estrogen promotes, what does it promote? Proliferation. And progesterone promotes differentiation. And when differentiation has to happen, what is the first thing that has to happen?
There is no mitosis seen.
No mitosis means that proliferation has to be shut off. And if proliferation is shut off, there is no mitosis. Okay, simple. So you either have normal proliferation and normal differentiation. You never get abnormal differentiation. The abnormal differentiation that we see is what we call pregnancy-associated changes. Yeah, where we think it is abnormal because it looks abnormal, but it is entirely physiological. It cannot be that you have got abnormal differentiation. The abnormal proliferation is because there is unopposed estrogen. Simple. And the unopposed estrogen can be of two types. They are always hyperplasic, but the hyperplasia can be typical or it can be, that means non-atypical and atypical. Simple. There is, if you just think of the endometrium as a target organ, absolutely no problems. And just each time you look at an endometrium, just say to yourself, what is acted on this endometrium? Because you're seeing it at one time point, right? So you want to know what has happened to that endometrium before it landed on your table. And I told you, it's so easy. Look and see, there are mitoses, there's been no progesterone. So now I'm looking at an endometrium that is estrogenized, and that estrogen there has been no progesterone in the system. Now, it could be a normal endometrium which has not yet reached 14 days of estrogen. Yeah. So it's not abnormal. It is an early proliferative endometrium. And that early proliferative endometrium would have reached 14 days, and then progesterone would have come into the system. Okay? But if you have an abnormal endometrium, which is showing you all that disordered proliferation, etc., there is no way that that endometrium would be acted upon by progesterone unless somebody gave the progesterone from outside. It's as simple as that. I think that the endometrium is a fascinating organ for the simple reason, a fascinating tissue for the simple reason that it is like mathematics. There are only two hormones that act, and you should be able to tell by looking at it what has acted on this endometrium. Okay, and I'm not talking about EIC or anything that is, I'm just talking about the endometrium and its, well, because EIC is a carcinoma, it's non-neoplastic endometrium. You shouldn't miss the carcinomas, but this is the non-neoplastic endometrium. Now, up to atypical hyperplasia and EIL, it is non-neoplastic. Okay, any other questions? You can always write to me on my email. I'm happy to answer it. Okay, Pooja, thank you very much.
Okay. Thank you, ma'am. Good night.
Aftal and Parul, thank you so
Bye,
much.
ma'am. Good night, ma'am.
Thank all the students. They were very interactive.